पहिला आपला ते येईल व्हिडिओ सिग्नेचर व्हिडिओ आपलं प्रेझेंटेशन मग त्याच्यानंतर टॉप जेव्हा शेअर स्क्रीन करेल शेअर स्क्रीन करून ठेवा ना साई कॅन वी शेअर द स्क्रीन
जस्ट अ मिनिट डॉक्टर
या पहिले प्रेझेंटेशन आणि मग ते सिग्नेचर व्हिडिओ झाल्याबरोबर ते देऊन द्यायचे.
We are live now.
Yeah. Shall we go share screen?
Yes.
Shall I?
Please go ahead, doctor.
Good morning. Welcome to season 2 Brain Teasers episode 3.
Doctor, your screen is not shared at all.
Huh?
Your screen is not shared.
It is not shared. Okay.
Can you start from the beginning, please?
Yeah, please. Is it okay? Is it okay now?
Yeah, you can start now. Correct.
Good morning. Welcome to Brain Teasers season 2 episode 3. Welcome. This is our signature tune for Brain Teasers. Good morning, friends, and a happy Friendship Day. Welcome back to the third episode of our monthly online quiz that is Brain Teasers. August is a month where we celebrate our Independence Day. Tomorrow also happens to be a Raksha Bandhan Day, an auspicious day. And more importantly, today is a Friendship Day. So everyone would want to go back to friends early, don't you? Yes, we promise we will not keep you away from your friends for long. Also, you can't go empty-handed to your friends on this day. So let's play the quiz and go back rich to your friends with lots of gifts. Being a festive month, we have lots of reason to celebrate and give happiness to our near and dear ones. Are you aware? August is also celebrated as Children's Eye Health and Safety Month. Pediatric blindness contributes to 0.08% of total blindness in our country, and about 30 to 72% of this blindness is preventable. Yeah, one. What happened? Sorry. One minute. So, are you aware? August is also celebrated as Children's Eye Healthcare and Safety Month. Pediatric blindness contributes to 0.08% of total blindness of our country. And out of that, almost 30 to 72% of this blindness is preventable. Becoming a blind in initial years becomes a liability not only to the family, but also adds a big socio-economic burden on our country. With the advancement in techniques, we have treatment for most of these disorders if picked and treated in right time. So let us page on this auspicious occasion in this auspicious month to save the sparkle in the twinkling eyes, which is also the reason for our tagline for today's episode was coined very aptly by Dr. Anurag Mishra, who is going to be one of our co-hosts today. Today, we are lucky to have two guests who are stalwarts in the field of pediatric ophthalmology. Not stalwarts, they are giants, I should say, and who will be enlightening us, all of us, with the pearl of the month. I welcome Dr. Pradeep Sharma, sir, Professor and Head Department of Pediatric Ophthalmology, RP Center, New Delhi, and Dr. Kalpana Narendran, Madam, Chief Pediatric Ophthalmologist, Arvind Eye Hospital, Coimbatore. Welcome you, sir. Welcome you, ma'am. Brain Teaser is a joint effort of a group of quizzers from across the country, also lovingly called as Gangs of Brain Teaser. They are all accomplished eye surgeons in various subspecialties of ophthalmology. But most importantly, each one of them has an itch for quiz. Amongst the gang, we also have people who are doing phenomenal work in the field of pediatric ophthalmology. Naturally, they will be sharing the quiz show as a quiz master today. I welcome Dr. Anurag Mishra, a pediatric ophthalmologist trained from Arvind Eye Hospital, and he's stationed at Cuttack doing phenomenal work there. Welcome you, Dr. Anurag Mishra, and Dr. Mohit Dogra from PGI Chandigarh to join me as quiz masters for today's episode. Sharing the mantle today, along with me from the house, is Dr. Shilpi Narnavre. She's the Chief Coordinator of Brain Teasers. Welcome, Dr. Shilpi, a lady with an eternal smile on her face. You can see on the screen in a very short while. Friends, your enthusiastic participation in big numbers is a matter of pride and encouragement to all of us. It encourages us to encompass new features, new themes to our show. One new feature which you might have noticed during the last episode was that on your screen, you could see the participant response. How many people answered, how many percentage of the people answered particular option. Now, from this episode, we will be streaming live on Facebook and YouTube our brain teasers for people who are just interested to watch and learn, but not play or participate. Also, people who missed the episode because of various reasons can archive it on Facebook and YouTube later. This program is for each one of us to enjoy and learn. Your sincere suggestions will definitely help us to make it more informative and fun. So do write to us on prashantkbhavankule@gmail.com. Your feedback will definitely help us to take this Brain Teaser platform to a bigger, higher level. Now I hand over the screen to Dr. Shilpi Narnavre for explaining you the rules of the game. Welcome, Dr. Shilpi. Stop sharing.
Good morning, friends. Welcome again. Happy Friendship Day to all of you. So, on this Friendship Day, lots of big prizes are at stake for you. Excited? Want to win? So, let's understand how to play the game fairly.
Next slide.
So, who can participate? Anyone from a PG to a practitioner, from kids in ophthalmology to the great veterans. This quiz has 5 sections and 5 questions in each section. Every question will be having the 4 options and only one amongst the 4 is the correct answer. So you have to select the correct answer and then also press the save response so that your response is recorded. Remember, don't be in a hurry to press the save button if you are not sure of the answer, because once you press the save button, you cannot change your option. This is what you will see on your screen. This is an example for your understanding. Identify the character shown in the picture below. Option A, Tom. Option B, Jerry. Option C, Donald. Option D, none of the above. timer will play for 20 seconds. You have to record your response only after the timer starts. If you submit your answer before the timer starts, it will not be recorded. Now, in this question, the answer is B. So, you have to first click the B option and then the save button. So, who wins the prize? Naturally, the one who responds the correct answer and answers fastest, that is, fastest finger first. So, what are the prizes? Every section has one winner. So, it means we have 5 section winners. That is not all. We have 2 mega prizes for the whole session of 25 questions, one for the runner-up and one for the winner. But remember, you can be section winner only for the one section. But don't give up because you can win the session prize with your consistent performance. In case of any discrepancy, judge's decision will be the binding. Now, if there is a tiebreaker, so what we should do? For section, cumulative performance of all the 5 sections will be considered. And if there is a tie for the session winner, that is for the runner-up and the winner, dice will decide your fate. Now look, what is at stake today? Amazon gift voucher of rupees 1500 for every section winner. Runner-up gets a gift voucher of rupees 5000 and the winner gets the 7000 rupees. It's not only the gifts. Winners, you will be invited live for the concluding ceremony where you will share the screen and interact with our guests today, Dr. Pradeep Sharma sir and Dr. Kalpana Narendran ma'am, who are idols for all of us. So winners, be alert. You will be sent a Zoom link as well as you will get a call on your registered mobile number. You will have to join the platform as soon you get the confirmation. I think enough of rules now. Let me invite Dr. Anurag Mishra sir, the young, charming, dashing pediatric ophthalmologist from Cuttack, who is very popular among his patients for his friendly behavior and straightforward approach towards the disease and its management. So now I hand over the screen for further proceedings to Dr. Anurag sir. Welcome, Anurag sir.
Thank you so much, Shilpi. Is my screen visible to all?
Yeah.
Right. Thank you so much, Shilpi, once again for that brawny introduction. Good morning, ladies and gentlemen, wherever you are. Greetings and regards from the land of Lord Jagannath. The quiz for you all starts right now. Dr. Prashant Babankule, the creator of this magnificent session and a smiling friend to the whole fraternity, Pan-India, has a middle name. Find out what the right answer is, find out his middle name, find out a way how to send in your right answers to me to claim your trophy. The trophy is a file of vaccine against SARS-CoV-2, which would be handed over to you latest by February 2021. So to claim your reward, go to the nearest chemist retailer, ask for the vaccine, get it, pay the price, get the bill, and claim your reward. Now, how ludicrously simple and tempting it must be for all of you. I think it has brought in a smile. Now, before I get a text from Dr. Prashant to stop this PJ and get on with some serious business, welcome you all to Section 1, Season 2, Episode 3 of Brain Teasers. I would fail my duties if I do not pay my gratitude to the quiz masters I saw and grew up watching, like Mr. Siddharth Basu, Dr. Narottam Puri, I'm a 90s kid, and Mr. Derek O'Brien. And I would also fail my duties if I do not pay my gratitude to occupy my chair here in this morning. My teachers in pediatric ophthalmology and strabismus, namely Madam P. Vijay Lakshmi, Dr. Shashikant Shetty as a faculty, and my beloved senior postgraduate, Dr. Jitendra Jethani, for making me who I am today. Right, so all set. Let's get on with question number 1 in section 1. I hope all of you are ready and your fingers at the ready on the screen as well. Here it comes, question number 1. The commonest variety of congenital cataract is, the options are A, lamellar, B, anterior subcapsular, C, nuclear, or is it D, posterior subcapsular? The time for all of you starts now. Here the clock goes into a stand deviation. I think you must have got your answers right. I hope so. The correct answer would be C. Nuclear is the most common morphological pattern of congenital cataract. Let's go to some of the explanations in this regard. This is a lamellar cataract, as we all call it. This is a lamellar cataract, but lamellar cataract is usually developmental. It comes in later. And when we, as pediatric ophthalmologists, see a lamellar cataract in a child, we become very happy because not only can we get our share, the child also gets his share of vision back. The prognosis is extremely good, and in most cases, it's associated with very mild forms of amblyopia. Nuclear cataract, on the other hand, is central and dense, and it is associated with severe amblyopia. It needs early removal as early as the anesthesiologist is ready to induce anesthesia. These cataracts should be removed. Globe anomalies and posterior capsular involvement and antenatal torch infections are common in nuclear cataracts. Both of these lamellar and nuclear cataracts can, however, be associated with the posterior capsular involvement as well. So we have to bear that in mind while operating. Anterior and posterior subcapsular cataracts are rare isolated forms when it comes to the pediatric age group. They're usually not congenital, and the visual implication depends on the involvement of visual axis. If they're central and cause even a mild deterioration in visual acuity, should be removed as early as you think is necessary. So that's the end of question number 1. All set to go to question number 2. Eyes on the screen, finger on the screen as well. Here it comes. This is a picture, more of a schema on the left-hand side. This is the same condition, the slit limb sagittal section of the disease, of the condition. You know what this condition is called, of course, but the question is, which of the following is not true for the image or the condition shown to you with the help of those two pictures? A, is it typically bilateral? B, not associated with globe anomalies? C, hydro procedures should be avoided? Or D, IOL placement in the bag is possible in most cases? Remember, which of these is not true is the question, and Big Ben starts ticking for all of you now. All right, time's up. Hosts of correct answers, I'm sure. The correct answer for this question would be, it's not true that it is typically bilateral. This condition is, of course, posterior lentiglobus or posterior lenticonus. They can be used interchangeably. It is associated with the progressive thinning of the central posterior capsule, which actually comes earlier. The cataract forms later. Before the cataract formation starts, if you look at these eyes from the slit lamp, you would find a typical oil droplet appearance in the posterior part. They're typically unilateral and sporadic in occurrence. However, they can be familial as well, associated with Loeys and Alport syndrome in particular. And if they are familial and associated with syndromes, they can be bilateral as well, but that's a rare occurrence. The capsular weakness is congenital, but the cataract develops later. And when the capsule develops spare, there's a rapid total opacification. If you do a B scan in these cases, you can find cortical fragments in the vitreous space as well. The symptoms the patients present with are myopia and reduced visual acuity. Hydro procedure should be avoided because it obviously causes a further drop because the capsule's open. The margins of defect, however, interestingly, are usually thickened and they're pretty strong to hold the IOL in the bag. This is one of my patients in the picture here, wherein the IOL has been placed in the bag. The patient's doing very well post-operatively, and the visual prognosis is quite good. So that was question number 2. So, talking about just a few other lenticular anomalies, structural anomalies. One of them is coloboma. Of course, it might or might not be associated with cataract. When it does, if you see a defect like this in the periphery, where the zonules are absent and the equator of the lens retracts towards the center, and ectopia lentis, where the lens is not there in its position and is distorted, can happen due to trauma or can occur congenitally. When it happens, then it might actually lead to secondary glaucoma, and you might have to medically treat the patient before taking him up for surgery. So that was all for question number 2. Coming up is question number 3. Hands-on. You can see 2 tiles. This is a video which I would be playing for you, a very short video, but you can see 2 tiles on the screen already, obviously to clandestine something. What is that? Let's watch the video. Nothing in it. A bimanual anterior vitrectomy is being performed in a pediatric eye after cataract surgery. And it was a traumatic cataract, as you could possibly have seen from the corneal opacity. But the facts that we are hiding in this video is what the question is based on. So here it comes. Which of the following is an ideal setting for anterior vitrectomy during pediatric cataract surgery? Is it A, cut rate of 100, vacuum of 100 as well? B, cut rate 250, vacuum 300. C, cut rate 1000, vacuum limit 300. Or is the right answer D, cut rate of 1000 and vacuum limit of 500? Your time starts now. Well, for all practicing ophthalmologists, I considered that to be easy speasy. Let's look at the right answer. The answer is C. You have to have a high cut rate with a vacuum limit moderate. The cut rate should be high and vacuum moderate to avoid traction on the uncut vitreous. And the vitreous, in case of children, is pretty solid. So you have to avoid traction at all costs. Too high a vacuum can drag without cutting, and too low a vacuum does not cut the vitreous hand because they have to engage in the cutter for you to cut them. Higher cut rates ensure precise saucer shaped creation at the anterior hyaloid face, which is exactly what we want to withdraw the scaffold for the lens epithelial cells to grow later on. You can choose a lower cut rate and a lower vacuum should you wish to choose your vitrectomy cutter for performing rhexis both on the anterior and the posterior capsule. Which brings us to perhaps the next question. I am sure you're enjoying the session or the section up till now. Here comes question number 4. In a 1-year child with unilateral cataract, the patching schedule following cataract surgery would be A, 20% of waking hours, B, 50% of waking hours, or is it C, 8 hours per day flat, or is it D, maximum time out of the waking hours? The longest hand of the clock starts eloping now. So there was some amount of disagreement between authorities regarding what the patching schedule should be, but we have, I think, achieved a consensus in that as far as patching schedule is concerned in sensory amblyopia. The correct answer in this case would be 50% of waking hours. When you have unilateral cataracts to deal with, they are tricky. Partial occlusion has been chosen over total occlusion, which was the cult earlier on, to avoid occlusion amblyopia. And besides that, it also causes a stimulation of binocularity, which is essential for children. So it stimulates binocularity as well as prevents occlusion amblyopia. The norm right now for unilateral cataracts is 1 hour per day up to 6 months. For example, if the child's been operated when he or she was 2 months old, you give it at 2 hours per day. and it keeps on increasing. You add an hour a day up to 6 months of age, and then on, it should be 50% of waking hours till 1 year. And if you see no improvement or not reasonable improvement is happening as per your estimation, then you can be more aggressive with your occlusion strategy, and you can, of course, go into maximum waking hours per day, or even can opt for a full-time occlusion 1:1 for the year of the child. Of course, it has to be under strict supervision, because for whatever reason, you do not want to lose anything in the eye which is not having cataract and which is not having amblyopia and which has perfect vision. So that has to be borne in mind. I think we have come to the last question for this section, and here it comes. This, ladies and gentlemen, is another Ujala, which is also Char Boond Wala. There was a claim from the manufacturer of this eye drop called Ujala. If you use it 1 drop 4 times a day, then it would ward off cataract. So this is claimed to be a medical management or a non-surgical management of cataract, claimed to be. Now let's look at a condition in which it can be reversed. Which of the following types of cataract can be reversed? Can be reversed if diagnosed at an early age. Is it blue dot cataract? Is it oil drop cataract? Is it pulverulent or pulverized cataract? Or is the answer D, cupuliform cataract? The clock starts ticking now. So time's up. I'm sure most of you have got it right. The correct answer is oil drop cataract. Now, this is associated with a syndrome. This is a syndromal association, and it happens in galactosemia. Pulverized and blue dot cataracts are congenital tiny opacities. They most often do not cause an obscuration of vision to a great extent, but the pulverulent cataract is coarser in its appearance than the blue dot cataract, which is much finer. Oil drop cataract happens in galactosemia, where galactitol or dulcitol accumulates in the lens and gives the appearance of an oil drop, as you can see in the picture out here. There's imposed dietary restrictions by the pediatrician who gets to see the child first, and once the dietary restrictions are imposed, it usually reverses and the lens becomes clear with time before an opacification process starts, of course. Cupuliform opacities are peripheral wedge-shaped opacities, and they're usually seen in adults. So that's the end of that. That's the end of the explanation. That's the end of this section. Before the back-end office tells us to who the section winner was, and we go on to announce the section winner, let me have the privilege of introducing the first star speaker for the day, Dr. Kalpana Narendran, who heads the cataract and pediatric ophthalmology department at Aravind Eye Hospital, Coimbatore. I had a brief interaction with Kalpana ma'am when I had been to Coimbatore to attend my routine rotatory postings in ROP. And for people who do not know about this, let me tell you that Aravind Eye Hospital, Coimbatore is a center of excellence for retinopathy of prematurity, and Narendran ma'am had her fair bit of share contributing towards the cause. She's going to speak us about visual acuity estimations and other things in pre-verbal and verbal children. I must tell all of you that Kalpana ma'am herself is practically non-verbal. She doesn't speak much. She's the quiet kind, but her whole focus, whole concentration is into her work. She has presented papers and has attended lectures internationally. She's a known figure everywhere. And she's won several civilian awards as well, like the Sake of Honor Award from Rotary Club, the local Rotary Club, the Potra Padam Pengal Award by the Lions International, Vocational Excellence Award from Rotary International again, and she's also been designated as the Best Doctor Award from MGR University, Tamil Nadu in the year 2014. She received an honorary doctorate degree from Vignan University, Badlamudi, Guntur, Andhra Pradesh, also I do not think she needs any introduction further. It is my privilege, ma'am, to welcome you to occupy center stage. I hope you can hear me, ma'am. Can I start? With your permission, I'll start the video that you have to share
Thank you
with
for the nice introduction. Yes, please.
All right, so here it goes, what ma'am has to give to all of us as the pearls of her wisdom.
At the outset, I would like to thank Dr. Prashant Bhawankule for giving me this opportunity. In my presentation, I will be sharing about visual milestones and visual assessment in children. Pediatric ophthalmology is quite a fascinating branch, but sometimes frustrating as it is difficult to examine children. So whenever a pediatric case is referred or it steps into a general ophthalmology practice, it seems difficult to handle them. In this presentation, I am going to share with you the normal visual milestones in a child, which will help in pediatric vision screening, which will help to detect many vision-threatening conditions, early intervention, and better visual recovery and long-term prognosis in these children. So I will be sharing tips on estimating vision in children in general practice. Babies and children learn to see over a period of time, like they learn to walk and talk. They're usually not born with all the visual abilities they need in life. The ability to focus their eyes, move them, and use them together in coordination must be learnt. Also, the visual information is sent to the brain and it's processed, and this process involves the eye, the central nervous system, and the behavioral development. Visual acuity is to assess the anatomical and functional status of the eye. When the visual system is immature, it is better to detect diseases at an early stage and treat them to prevent permanent visual loss. Neonatal vision. So visual system is relatively immature at birth, and most of the development occurs during the first year of life, which is a very dynamic period in visual development. So any pathology or insult which impairs the visual development during this period can lead to a long-standing impact. At birth, the babies only see blurry images. They only appreciate black and white images and the contrast. So they are able to see mother's face at the edges, and they are able to see the eyes. And usually the distance where they can appreciate an object would be around 8 to 10 inches away. The eyes are sometimes uncoordinated and may look cross-eyed. The infant will blink in response to bright light or touching the eye. During the first month of life, the eye starts working together and the vision rapidly improves. The eye-hand coordination improves, and the child starts looking at faces and pictures with contrasting black and white images, can follow objects up to 90 degrees, watches the parents closely, and tearing production starts. During the second and third month, the baby starts recognizing the mother's face. It's able to see objects as one image. And fixation develops. If the infant's eyes are not well coordinated and appears to be crossed, then evaluation is needed. You should worry when the baby is not fixing or following light. At 4 to 5 months, the baby becomes much more aware of the environment. They can follow a moving toy or a rolling ball, and the hand-eye coordination is improving. In this period, the control of eye movements and eye-body coordination continues to improve. Another hallmark feature is the depth perception begins during this period. The baby can pick up a toy that is dropped, develops color vision, it can play peekaboo, and begins to watch objects that are moving fast. At 12 to 48 months, they almost reach an adult stage. They're able to place shapes in proper holes. They recognize familiar objects and pictures in the book, and they're able to point out objects and also respond to gestures and actions. They're able to scribble with crayon pencil, and the vision usually reaches 20/20 during this period, and they have a normal color vision. By the 6th year, the child is able to recognize and recite the alphabets. They're able to read the Snellen's chart and has complete depth perception and has a capability to name coins, money, and to use scissors. Coming to the estimation, usually children are divided into pre-verbal and verbal children. The earliest visual acuity test would be blink reflex. Like when you show a flashlight, the child starts blinking its eyes. So that is the blink reflex. The next test would be fixing and following light. So you can see here this child, this can be done at various distance. The next will be the fixation pattern. If you see here the child on the left, you can see the corneal reflex, which is seen very well in the center. Whereas the child on the left, you can see that the left eye is a little deviated, appears esotropic. So just by throwing a light and making sure that the eyes are orthophoric with the fixation center, you can judge the visual acuity in a child. The CSM method, the central steady maintained, is a simple method to check the visual status, usually done with one eye fixing an accommodative target held at 40 cm. The C refers to the location of the corneal right reflex. Normally it is in the center of the cornea and it's symmetrical. And S refers to steadiness of fixation, and M is referring to the maintenance of the fixation. So if the child is not able to maintain, that indicates a decreased visual acuity. This is just a picture to show how the examination should be done. Always uniocularly it should be done. And this is a child here where you can see that when the left eye is patched, when you are offering her a chocolate, she is able to pick up. The same thing when the right eye is patched, is resisting occlusion. She is not able to pick up the chocolate and she is crying and she is trying to remove the patch. The Bowie Candy test is a very simple test which can be done in the office to vision assessment by giving the small different size candies. It's also called as cake decoration, and the vision approximately corresponds to 624. The next test is the Lea gratings. Is a preferential looking test, is the principle, and here the gratings of various frequencies are shown to the child. Simultaneously, the plain placard side by side, and this can be done in children usually between 3 months to 1 year of age. The Taylor Acuity calls a similar preferential looking test where you have black stripes of varying thickness, and this is how the test is done. The examiner sits behind, there's a small hole, and observes the patient's face and the movement of the eye. The next test is the Cardiff Acuity card or the vanishing optotypes. This is a test which gets done between 1 to 3 years of age, where you look at the optotypes which are diminishing in contrast. The Lea symbol test is for older children, where the child is asked to match the symbol shown at distance with the symbols given in the card child's hand. This is usually meant for preschool and kindergarten age, and they have different shapes which will attract the child. The Sheridan-Gardner test is another flip card test which can be done in little older children and also in toddlers. So this has a matching card. The person has the letters in a distance and child is able to match, and the visual acuity can be got equivalent to a Snellen's chart. To conclude, this is just about the visual milestones in children, and parents play an important role in helping the development of the child's vision by always looking for warning signs and vision problems. A preschool evaluation is mandatory to prevent vision-threatening complications, and I hope the tips which we shared will help the general practitioners to do some justice to the children who present to their clinic. Thank you.
Thank you so much, ma'am. I'm sure had it not been a virtual meeting, the whole hall would have erupted with clatters the moment it ended. I think it was a succinct summary of something that is pretty prolix in its dimensions. Ma'am, just one or two questions that I would like to ask you. If the patients obviously would not know who is a pediatric ophthalmologist and who specializes in the subject, if a child very small, say 2-3 months old, comes to the clinic for whatever reason, should we all have the facility of a cake decoration test, or simply look at the CSM function test to roughly assess the visual acuity of the child? Be the child not come for visual acuity issues, be that if the child has come for any other issue as well. Do you think so?
I think a simple CSM test will roughly give you an idea. So you can make out uniocularly if you check the CSM. A cake decoration is also not a very expensive investment. So, but just to see the child preliminary who comes with an allergic conjunctivitis or watering or something like that, I think a CSM would be the best method. You can easily, judge the quantity of vision in the child.
The reason why I put that question across to you, ma'am, is because even when children come at the school-going age, if they do not complain of anything specific, like I cannot see letters from the blackboard, and they would have come to us for a simple recurrent VKC, should we give importance to visual acuity estimation? Why I say this is because even the parents sometimes resent this thing. They say, my child does not have a complaint with regards to his vision. Why should we check the vision, come back to you after some time to check and get his vision? Should we counsel them that this is always important, even if the child is not complaining?
I think it's very important because sometimes, we pick up a lot of eye problems when they present with the simple ailments like allergic conjunctivitis. I think you should counsel the parents and make it a mandate to any patient who presents to the clinic, adult or a child. A visual screening is a must. Even I've seen like adult patients, 45 years, coming for some other problem, and then we find out one eye is amblyopic, which even the patient would not be aware of. So it's better to do a visual acuity estimation in all the children. And if you don't have special tests, even a Snellen's acuity chart would be enough, which has sometimes the images of, like flowers and, cats and other things. So that can be helpful for a child. I think you have to convince the parents.
But when it comes to the next step, which is prescribing glasses, would you recommend that a general ophthalmologist can, what's the threshold level from wherein he can prescribe the glasses, or below which he should take an opinion or cross-check it with a pediatric ophthalmologist that's available nearby?
I think comfortably, if it is like simple myopia, I think he can go ahead and give the glasses. I think if the child is above 5 years, it's comfortable for a general ophthalmologist to give the glasses. But if there is any accommodative component, if an accommodative esotropia and or a high hypermetropia and things like that, then I think it will be better to refer to a pediatric ophthalmologist. Otherwise, a simple myopia above the age of 4 years or 5 years, a general practitioner can definitely give the glasses.
Thank you so much for those pearls, ma'am. You stay with us right throughout the campaign here today. You would be having some other honors to do as well. And we are so privileged to have your company on a Sunday morning. You've really made our day. Thank you so much for being with us, ma'am.
Thank you. Thank you. My pleasure too. Thanks for the invitation.
So, ladies and gentlemen, here we come to the winner. We have finished our computations. The section 1 winner, here it comes, is known by the name of Dr. Akanksha Darda from Nagpur. Here's to you, Akanksha. I don't have the numbers. How many did you get correct? But certainly, we would like to see you at the end of the program. Do join with us on the Zoom platform so that we can have a little interaction and then on can felicitate you for the effort. Thank you so much. That concludes section 1. As we go to section 2, and time for me to hand over the center stage to my co-host. He hails from Chandigarh, Punjab. And the first commodity that you get yourself reminded of when you speak of Punjab and Chandigarh is lassi, which is sweet optimally, soft optimally, tender optimally. And that's how this person is: sweet, soft, and tender. Thick as an ophthalmologist, chic in his looks, crunchy with his skills, punchy with his voice. Ladies and gentlemen, please put your hands together for my co-host for the day, Dr. Mohit Dogra from PGI Chandigarh. Mohit, thank you so much for co-hosting the show with me. It's a privilege, and I welcome you to come and occupy center stage and carry on the show of Brain Teasers Season 2, Session 3.
Thank you, sir. Thank you for those. I mean, I should have gotten my matrimonial kind of written from you, sir. My ad in the paper. I mean, I don't think I could have used those words for me ever, even if I wanted to. So thank you so much for those more than kind words. And without much hullabaloo, I just want to thank Dr. Prashant Bavankule, sir, Dr. Shilpi, the entire team at Sarakshi Netralaya, Entod, and everybody who's actually taken a lot of pains during this global pandemic to kind of stitch this together and come back in a better way in season 2 Brain Teasers, and also to give an opportunity to me to be part of this excellent educational platform. So once again, sir, thank you very much. And we'll delve straight into section 2. So here goes. So this is the first question of section 2, or the MCQ 6. A 13-year-old male presents with these clinical findings, as is seen in the left eye on the right of your screen, and has a visual acuity of 2/60, and the right eye is normal. Which is the most accurate statement about this condition? A, past an vitrectomy with epiretinal membrane peeling should restore normal vision. B, the fellow eye has a 10% risk of developing this pathology. C, the OCT features are pathognomonic. Or D, that most affected children with this will have mental retardation. And your time starts now. I hope most of you got your answers in, and the correct answer is option C, that the OCT features in this condition are pathognomonic. And we'll just quickly come to the explanation that. So I'm sure a lot of you actually got it. This is a combined hematoma of the retina and the retinal pigment epithelium. It's a benign lesion. It's usually unilateral, although in about 10% you can have a bilateral disease. And in those, you must rule out a neurofibromatosis type 2. It's generally peripapillar, could be macular as well, slightly elevated, variably pigmented, and has retinal vascular tortuosity and retinal vascular changes. I think if there was one carry home message from this kind of question, then it would be that if you see a ERM, epiretinal membrane in a young patient, whether secondary to trauma or not, you must strongly consider that underlying diagnosis of a combined hematoma of the retina and the retinal pigment epithelium. It generally, presents because the patients bring the kid to the pediatric ophthalmologist and with the complaint of squint, or is just detected incidentally during a school screening, or just low vision detected incidentally. The OCT is diagnostic, and it shows the typical sawtooth appearance of the inner to the middle retina, with no disruption of the outer retinal layers, and you can see that there. You can see that sawtooth pattern of the inner to middle retina, whereas the outer retinal layers are relatively unaffected. And very, very, very seldom do you need a pars plana vitrectomy to remove the epiretinal membrane. Only if you have documented that there is progression of the membrane on OCT, along with reduction in vision that you have documented yourself over time, would you be marginally inclined towards offering them surgery. So the correct answer here was C, because the OCT was just pathognomonic. With this, we come to the second question of this section, which is also the MCQ 7. So a 5-week-old infant with a birth weight of 1,600 grams and was born at a period of gestation of 32 weeks and has the following clinical picture. So you can see the REDCam fundus image photo of the right and the left eye on the right. Which of the following statements about this condition is true? A, it needs intravitreal anti-VEGF along with laser photocoagulation. B, it needs urgent vitrectomy. C, it needs nothing. You just sit on it and you observe the patient. Or D, all of the above. And your time for this starts now. That was a bit of an easier one, and I'm pretty sure most of you got it right. And the answer, I don't think it's very tough. So this actually needs a combination of anti-VEGF and laser photocoagulation. You could argue with that, but this definitely requires treatment and does not require vitrectomy at this stage. So just this is the typical half-zone ROP in which the vessel maturity is not gone beyond the macula, sometimes just up to the fovea. Aggressive posterior ROP, this was actually APROP, which is severe plus disease, flat neovascularization in zone 1 or posterior zone 2. This was actually posterior zone 1 disease, intraretinal shunting, and it doesn't go through the regular stages that the ICROP, told you about, stage 1, stage 2. It can go straight away to retinal detachment, and hence the absolute emergency to treat and not sit on it and observe. The urgent treatment is with confluent laser photocoagulation, and especially in zone half, especially as was shown in the images in this question, it is recommended that you combine it with anti-VEGF and kind of stagger the laser to maybe allow some of the vessels to grow. And I couldn't end the explanation for this without just reiterating, because I think any number of times the ROP screening guidelines in our country are reiterated, it would I don't think it would be enough. So these are the guidelines. Any kid born with a gestational age equal to or less than 34 weeks, birth weight less than or equal to 2,000 grams, and even if the kid was born after 34 weeks, had associated risk factors, let's say prolonged hospitalization, intracerebral hemorrhage, required oxygen for a longer time, other septicemia, again they have to screen. And if the treating pediatrician or the neonatologist feels, irrespective of the first 3 guidelines, that they would just want the ophthalmologist to take a look, that is also now part of the formal screening guidelines. So I think this is less than 34 weeks, and anyone less than 2 kgs is something that I think everyone should remember. With this, we come to the third question of this section of the MCQ 8. And here it is. So basically a 7-year-old girl, she presented with diminution of vision in both eyes and had the following clinical and imaging features. We have just put the images of the right eye. You have to trust us when we say that the left eye was identical. What is the most likely diagnosis? Is it A, leukemic retinopathy? B, is it a cone dystrophy? C, is it an autosomal recessive bestrophinopathy? Or D, is it a chronic central serous chorioretinopathy? Our retinal terms are really long and confusing. So and your time now. That was a bit of I won't say a tough one, but a lot tougher last one, right? So the correct answer is option C. That's a multifocal Best disease, if you want to call it, but it's basically autosomal recessive bestrophinopathy. And we'll just come to the explanation. So the autosomal recessive bestrophinopathy belongs to the same family as the well-known Best disease. So it's basically, but in contrast, it's seen in young females and not in males. It's seen in younger females also. Mutation is in the same Best one gene. They are predisposed to choroidal neovascular membrane formation, and a lot of times will just come to you after they've bled and lost some central vision. The pathognomonic test, in the absence of a genetic confirmation, which in our country, in most centers won't be available, is an electrooculogram in which the Ardens ratio, the light peak, is either very, very low or could be absolutely absent. The fundus autofluorescence, as was shown, is characteristic as all of those clinically appearing yellow vitelliform lesions light up on the fundus autofluorescence. They are brilliantly hyperautofluorescent, and they'll be multifocal and giving a typical starry sky pattern. The OCT shows findings similar to adult CSC, chronic central serous chorioretinopathy. So there is lucency between the photoreceptors and the RPE, and there are those shaggy photoreceptors which you can see, which is also kind of diagnostic. A cone dystrophy, as has been shown by that representative image on the right, typically will have defective central and color vision. If they have it early, they'll have hemerolopia, which is basically kind of photophobia. In the later stages, you might have bullseye maculopathy, and you'll have classic ERG abnormalities in which the cone part will be affected more and the rods will be kind of spared, at least in the early part of the disease. Leukemic retinopathy has typical retinal vascular changes, will have hemorrhages of all kinds, pre, intra, subretinal, multiple can have cotton wool spots, can have rot spots with basically white-centered hemorrhages and vascular sheathing, akin to that photo which has been shown there. With that, we come to the fourth question, and here it is. So this is a spot diagnosis, no long story for this. So what is that? This is the right and left eye of the same patient. Is it A, a bilateral retinal vasculitis? Is it B, a albinotic fundus? Is it C, lipemia retinalis? Or is it D, a bilateral central retinal artery occlusion? And your time starts now. One of the simpler ones in this round. I think most of you would have gotten that. That is typically lipemia retinalis. Now, what lipemia retinalis is that it's typically seen with hypertriglyceridemia, with triglycerides at least above 1,000 milligrams, and it'll not be seen in patients with increased LDL or HDL. You need triglycerides which are high molecular weight, because why this appearance is there is because the retinal vessels become kind of saturated with the pink or creamy. And they look pink or creamy because they scatter of light by these triglyceride laden chylomicrons in the plasma. So you could have a very high LDL count, but you won't get this appearance. So it's actually been divided into 3 stages. The stage 1, you might miss on a posterior pole exam because just the peripheral vessels become creamy white. In stage 2, the peripheral and the macular vessels are white. In stage 3, not only are the peripheral and the macular vessels white, but you also get a kind of a salmon-colored retinal hue, basically a choroidal hue, the kind of hue you get from the fundus, that is actually changed. So our patient actually had stage 3 because the central peripheral vessels were white and the hue of the fundus was salmon-colored. Why it's not retinal vasculitis, I think it's kind of self-explanatory. Generally segmental, you would have some hemorrhages or some typical sheathing. There would be change in vascular caliber and might be associated with ocular inflammation. The albinotic fundus, like it's shown second to the top on the right of this screen. The fundus is hypopigmented. And there are a lot more vessels visible. They are the choroidal vessels. However, the vessels of the retina that are visible are normal. There's no change in caliber and there are no hemorrhages. Old central retinal artery occlusion would unlikely be bilateral. It could be, but it would look something like that. There would be a lot more pallor, and there would be arteriolar narrowing and not a change in the color of the arterioles and the retinal vessels without a change in caliber. So with that, we come to the last question of this round, and here goes. So which of the following is true about this disease in an 8-year-old female? So A, the polyarticular type is most common, is the most common subtype associated with this ocular involvement. B, it needs systemic steroids and immunosuppressants. C, hypotony responds to topical difluprednate. Or D, cataract surgery does not require any special precautions. And you can see the 3 different photos below. Your time for this question starts now. The end of this, and we'll just give you the correct answer. So that was a patient of juvenile idiopathic arthritis associated uveitis, chronic uveitis, and it needs, the correct answer is B. We'll just look at why that is. So JIA, or juvenile idiopathic arthritis, is basically autoimmune, and it basically requires arthritis of at least 6 weeks duration in children less than 16 years. And the chances of getting uveitis, of which anterior uveitis is seen in most, is about 30 to 35, 40%. It's higher in patients who get oligoarticular JIA or less than 5 joint involvement and presentation, more in females, more in people who have ANA activity, and more in which the arthritis onset is before 4 years of age. Again, one of the hallmarks is that, although it can be pretty severe and most patients present with complications, as you saw in this, for this unfortunate girl, but there is absence of congestion or photophobia. So it's basically inflammation of the anterior segment mainly, but in the absence of congestion or any other signs of a red eye. And the complications, a couple of which were seen here, are a band-shaped keratopathy, complicated cataract, there could be glaucoma, and more fearsome is the hypotony, and there could be macular edema. So in this patient, you saw the cyclitic membrane on the UBM, you saw the band-shaped keratopathy, and you saw the complicated cataract in a white eye. So the management, basically, they need topical and systemic steroids because it's an ongoing long-term illness, and you want to kind of keep them off steroids for as long as possible. They need systemic immunosuppressants as well, which is long-term. Methotrexate is preferred in a lot, and biologicals are kind of also being pushed as the first line for JIA-associated uveitis as well now. However, the one thing which needs to be kept in mind is that, the contraindications of IOL implantation, you can implant the IOL, although I think an experienced surgeon who knows what he's doing should be doing that and should be managing with the uveitis. But if you have hypotony, if the age is less than 4 years, or if there has been a poor outcome of an IOL implant in the fellow eye of a patient, I think IOL should be withheld, and whether a lensectomy or whatever is planned, but an intraocular lens should be withheld in those circumstances. With that, we come to the end, and now we'll be heading on to a commercial break. None of these events, and whether they be webinars or as is in this case, online educational kind of a forum or a organizational event, is possible without the help of commercial partners. And in this regard, I think we must thank Mr. Kishore and Nikhil Masurkar from Entod Pharmaceuticals for giving unstinted support to this. And without their help, as we all know, it's difficult to kind of bring it all together. So again, a shout out to them. And I'll just be playing a little bit of a video on behalf of their company. Again, a shout out to Endot Pharmaceuticals for this unstinted support to Sarakshi Nitrale and Dr. Prashant Vankule, sir. With this, we come to, before I actually hand over the platform back to my co-host, Dr. Anurag, I'll just be giving out the date for the next quiz. The next quiz would be held on the 6th of September at 10 a.m., which is a Sunday. The details for which will follow shortly, as Dr. Shilpi and Dr. Prashant will get to work on, what the kind of theme would be, and who would be conducting it. So just to give you a date, 6th of September, next month, 10 a.m. Hope to see you all there after this is over. And I would also like to, again, reiterate what Prashant sir said in his introduction. That's his email right there at the right-hand side bottom, and his WhatsApp numbers. Any kind of feedback, constructive, not so constructive, although I'll be honest, we just appreciate constructive. We're very selfish people. We don't take criticism well. But any kind of feedback, jokes apart, I think is always welcome, just to make us bloom like that flower which is blooming again and again. So just that, and with that, we come to who has won this section. So so the winner of section 2, who I think has also won on one of the previous quizzes on one of the, I think episode 2 maybe, or maybe episode 1, is Dr. Uday Tekchandani from Chandigarh. And I know him, he's from PGI. So congratulations, Uday. And you know the drill. You've actually done this before, right? You won one of these things, I think in one of the previous episodes. So keep your Zoom, keep your mobile phone on, and expect the team to get in touch with you to give you a link for the Zoom platform meeting. And with this, I hand it over back to Dr. Anurag, who I'm sure is going to keep us spellbound with another terrific section of quizzing. Dr. Anurag, please.
Thank you so much, Mohit. I was enchanted, personally. I must admit that I'm a nutter when it comes to retina. But then I was enchanted, glued to the edge of my seat while that section was on. Very, very well carried out indeed. Congratulations, Uday, your mate from PGI. So you guys not only quiz hard, you also answer hard and win hard. So congratulations to the first 2 section winners, and we'll move on to section 3 now. The first question of section 3, season 2, and session episode 3 of Brain Teasers is on its way to all of you. This is a rope well which passes through a pulley. The reason why it passes through a pulley is that the pulley stores its torque and lets us do more work with minimum effort put. There is an extraocular muscle which also passes through a pulley. And because of its strange triangulation, it does work which is pretty peculiar and specific to itself. You know the name of the muscle, I will not go into that. But the question here is, which of the following best describes the primary, secondary, and tertiary actions in that order of the muscle shown? A, Is it intorsion, elevation, and abduction? Is it intorsion, depression, and abduction? Is it C, intorsion, elevation, and adduction? Or the right answer, D, intorsion, depression, and adduction? The time for all of you starts now. Time's up. There's no need to say that I was lamenting on the superior oblique muscle. You got that right, but let's see how many of you got the answer right, which is B, intorsion, depression, and abduction, though the muscle is superior in its location. So the oblique muscles are primary cyclorotary muscles. Every extraocular muscle has multidirectional phenomenon function, as we know. Unique placement of the obliques enable them to perform their unique actions. Obliques assist vertical recti in producing vertical movements, particularly in the extremes of cases where they become the predominant muscle to produce vertical movements. This is a mnemonic that was taught to me when I was a fellow. Superiors are intorters, obliques are abductors. So if you remember this, then you would probably be able to decipher the enigmatic helix of cyclorotary muscles and their primary and secondary actions. The superior oblique muscle originates from the body of the sphenoid bone, medial to the origin of levator palpebrae superioris and superomedial to optic canal. Insertion is, it loops through the trochlea and inserts into the sclera in the posterior temporal surface of the eyeball where it fans out. And the anterior two-thirds of the fanning portion of the insertion actually are intorting fibers. So when we want to weaken the intorting action, we have to sever the anterior two-thirds of the fanned out fibers. The innervation is trochlear nerve, as we all know. Superior oblique palsy is pretty common in closed head trauma where you do not have a blowout phenomenon happening, but still there would be a palsy of the superior oblique resulting in hypertropia of the affected eye. The other syndrome is Brown syndrome, which can be congenital, which can be acquired as well. When the tendon is inelastic and it fails to relax, for which it appears that the inferior oblique also is paretic. Superior oblique myokemia is uncommon, and there occurs a vascular decompression of the fourth nerve. It is associated with repeated brief involuntary episodes of the movement of the eye. So that's all about this elusive superior oblique muscle and its primary, secondary, and tertiary actions in that order. That's question number 1 for you. Coming up next is question number 2 in this series. As you can see in this picture, retinal detachment is being tried to be fixed by some terrific retinal surgeon like Dr. Prashant himself. And what he has done here is put in a buckle. So the question for this, or based on this picture, would be, which of the following is the commonest reason? Which of the following is the commonest reason of strabismus following the procedure shown in this image? A, is the commonest reason a slipped muscle? B, is it a disinserted muscle? C, is it due to fat adherence? Or D, is it because you selected a 240 band over a segmental buckle? The clock starts ticking now. Right, there must have answers flown. Choices A and B are obvious reasons for causing strabismus following RD surgery. However, the commonest reason why strabismus happens is because of fat adherence. It's an interesting phenomenon. The posterior Tenon's capsule. The Tenon's capsule is divided into anterior and posterior, as we all know, from the points where the recti penetrate the Tenon's capsule to come close to the sclera. The Tenon's capsule in the posterior part essentially separates fat from the globe, and it is violated during dissection. Strabismus surgery also produces the same. However, the area we dissect to free the muscles much smaller than what you have to do when you're putting in a buckle or a band. It's likely to happen more with broad segmental buckle than a belt because it's broader. So you have to create more space to put it in, and the posterior tenon's capsule is more likely to be violated. It causes disinsertion, muscle disinsertion is caused while hooking it if you're not gentle enough, if our assistants are not gentle enough. And the slip of muscle more commonly happens in squint surgery if you're passing your sutures very close to its insertion and the sutures only involve the muscle sheath and the muscle belly is not involved in the suture. That can happen, a muscle slip, and it recedes posteriorly, causing strabismus thereafter. So that concludes question number 2. Let's go on to question number 3 in this section. As you can see, this very interesting face made by this child just before he receives an immunization. There are smiles all around. The child has a quizzical look on his face. So let's come to the question based on this picture. A child presents to you with a paralytic strabismus following an immunization. The nerve that is most likely to be involved in this paralysis would be cranial nerve 6, that stands as choice A, or is it B, cranial nerve 3, C, cranial nerve 4, or is it D, both A or B are true? Send in your answers. The time starts now. Time's up, ladies and gentlemen. Let's look at the right answer. The nerve that is most commonly or most likely to be involved in a situation like this would be cranial nerve 6. Viral infection and immunizations are common causes of cranial nerve 6 paralysis. However, it is likely to resolve if it resolves after a viral infection or an immunization. It is likely to resolve spontaneously in 6 to 10 weeks of time. The other causes of cranial nerve 6 paralysis or palsy would be head trauma, neoplasms, and inflammatory conditions. Grad-Inigo syndrome, for example, which is associated with mastoiditis or meningitis, can also lead to cranial nerve 6 paralysis. Cranial nerve 3 nerve palsy is most commonly idiopathic. However, inflammatory or traumatic can also be causes leading to the same. It's very easy to confuse congenital cranial nerve 6 paralysis with Duane's retraction syndrome, but the angle of deviation in a palsied muscle is much, much more than DRS. DRS is also associated with a head turn, with a face turn to achieve binocularity. And there are typical fissure changes and vertical shoots, upshoot and downshoot in adducted positions of the eye to differentiate this condition from a cranial nerve 6 paralysis. So that leads to the next question in the series. Look at this condition, which is a schema. An occluder is applied to one of the eyes in both the segments of the picture. Look at the behavior of the other eye and look at the behavior of the eye that is in question or under the occluder, which is not a full occlusion. That's a very valid hint. Which of the following conditions does the schema depict? Is the answer A, bilateral superior oblique palsy, B, dissociated vertical deviation? Is it C, Graves' ophthalmopathy, or is it D, vertical Duane syndrome? The 20-second slab start rolling now. Right, so this is most likely a Spielman occluder, which is not typically opaque. It allows some amount of light to transmit through so that you can see the behavior of the partially occluded eye. The correct answer for this schema is dissociated vertical deviation. All vertical deviations would follow the Hering's law. If one of the eyes is going up while the other eye is fixing, when the deviated eye or the hypertrophic eye comes back to take up fixation, the previously normal or centered eye would go downwards into a hypertrophic position. So that's what Hering's law is all about. But in dissociated vertical deviation, this is violated. Both the eyes go up while the other eye is fixing to the most commonly DVD is not manifest. It's a latent DVD. So to elicit this deviation, you have to occlude it with a partial occluder so that you can notice the behavior of the eye which is under occlusion, while the other eye, which is relatively occlusion free, can take up fixation. So that's about this dissociated vertical deviation and the question regarding that. We come to the last question of this section now. What you see here is a can of preserved food. It is sliced oranges, sliced tomatoes, sliced fruits and vegetables. When the can looks like this, you can see the top of the can, which is bloated and about to burst open, should be discarded and not consumed. The reason why it should be discarded is it is most likely infected and there sits a gas-forming organism inside. We dread its name. The organism is most likely Clostridium botulinum. Clostridium botulinum produces a very powerful, one of the strongest toxins known to mankind, and a few milligrams are supposed to wipe out the whole mankind from its existence. However, Botox, the toxin produced by this organism, can also be therapeutically used to treat several medical conditions. Let's look at the condition which Botox cannot treat. Which of the following is not an indication for the use of Botox for treatment of strabismus? The choices are A, preventing risk of anterior segment ischemia, B, tight rectus muscle in infantile esotropia, C, small angle strabismus where incisional surgery is denied by the patient, or is the right answer D, tight superior oblique in Brown syndrome? Which of these conditions is not an indication? Your time starts now. Time's up. I'm sure most of you would have got that right because it's pretty simple. The correct answer is D, tight superior oblique muscle in Brown syndrome. Botox is a lethal substance, as we were discussing a few seconds back. The mechanism of action is at the synapse or neuromuscular junction level, where it stops the acetylcholine from binding to its transmitter. The superior oblique muscle is a largely tendinous muscle, and for Botox to act or cause a paresis, temporary paresis of a muscle, it has to be injected into the muscle belly. Brown syndrome is a condition where the tendon part is involved, so it does not act. It's likely that some of you would have thought that small angle strabismus Botox is not injected. However, it stands as an indication. If interventional surgery or incisional surgery is denied by the patient, you can titrate the dose. Of course, it's a difficult job to do, but when the patients deny intervention, you can rely on Botox to do the job for you. It is also indicated in tight muscles, like in strabismus fixus, or tighter muscles in infantile esotropic conditions. And it is also something that you can zero in on if you want to handle more than one muscles, and there is a risk of anterior segment ischemia since you are severing the anterior ciliary arteries, branches that run with the erectile muscles as well. So that concludes our section. The section 3 of this session. And before we compute the results and announce the winner of the section, let me take this privilege, and it would be my humble prerogative to introduce our whole team of Brain Teasers gang to all of you in the form of this video. Hang in, ladies and gentlemen, for our team introduction.
T, E, A, M. When I say team, you say work. Team, 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 team. Hand in hand, when we work together, it's teamwork, and that makes things better. When I help you and you help me, we're like players on the same team. Working together, everybody wins, and teamwork helps you make new friends. The work goes faster when we sing songs, so come on, team, and sing along. T, E, A, M. When I say team, you say work. Team, 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 team. T, E, A, M. When I say team, you say work. Team, 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 team. When you're in a team, it's always fun. You notice two heads are better than one. To cooperate is really great. People on your team are called your teammates. As a group, you can achieve your wildest dreams. Work together because there's no I in team. Doesn't matter who's last and who's first, as long as everybody provides the teamwork. T, E, A, M. When I say team, you say work. Team, 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 team. T, E, A, M. When I say team, you say work. Team, 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 team. T, E, A, M. When I say team, you say work. Team, 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 team. Hand in hand, when we work together, it's teamwork, and that makes things better. When I help you.
Dear friends, this is the team of brain teasers who have conceived this. Anurag Mishra is wrongly placed the only honors to me, which is wrong. In fact, the whole concept, though concept was ours, it was now whatever big proportion it has assumed is because of all the brains which are involved in creating this. This is the brains from across the country who are quizzers, who have been doing quizzes at respective part in various forums. I'm really thankful to the whole team for creating such a beautiful platform for all the youngers as well as the practitioners. Thank you. Anurag.
Thank you so much, sir. And there's a smile on my face, both because of the fact that you came in with your wonderful voice to add on to the video, and also because of the fact that I'm about to announce the winner of section 3. Hanging tight out there. The winner's name is Dr. Romana Fazal from Puducherry. Dr. Romana, please keep your phone switched on and connected to the internet. You're going to get a message soon from the backend team. Come and join us later for the felicitation ceremony. We're so happy with all of you. We're so happy for the effort put in. With those words, we come to section 4, and it's time to go back to Dr. Mohit and his exquisite expertise in the following round to be shared with all of you. Welcome, Mohit. Come to the center stage. Your audience is ready for you.
Thank you, sir. And as always, you're the toughest act to follow. And I would just, plead with the audience to bear with me while they, wait with bated breath to get back to you for the final section, sir. And with this, I'm just going to, delve straight into section 4 and, question 16 of this entire quiz, but the first question of this section, and this is actually the first kind of trivia. So which Indian ophthalmologist, the photo of whom is shown there, is regarded as the father of pediatric glaucoma surgery? Definitely as far as our country is concerned, but even otherwise. So is this Dr. Anil K. Mandal? Is this Dr. Ronnie George? Is this Dr. Harsh Kumar? Or is this Dr. Barun Nayak? And your time starts now. Yeah, no marks for guessing. I think, so the correct answer is A. That's Dr. Anil K. Mandal. He's, sir's, in charge of the glaucoma service at the LV Prasada Institute, the prestigious institute in Hyderabad, was trained at AIIMS in Delhi. Again, the RP center at AIIMS. I mean, who doesn't want to, walk in the walls of that place? And his seminal work, without getting into too much detail, in the early to late 1990s, established the procedure, which is commonly done by a lot of people to help and alleviate congenital pediatric-related ocular blindness. So he's the one who actually kind of cemented the role of combined trabeculotomy and trabeculectomy as the procedure of choice for treating pediatric glaucoma eyes in hazy corneas. And dozens and dozens of ophthalmologists and a lot of patients owe a lot to this man. So shout out to Anil K. Mandal, sir, for that. With that, we come to the second question of this section, or the MCQ 17 for the overall quiz. So this is going to be a small video, and what you need to do is identify the instrument which is being used in this surgical clip. And the Options are, is it A, a trabectome, B, a Harm's trabeculotome, C, is it a Kelly's punch, or D, is it a corneoscleral scissors? And your time starts now. And I think anyone who's seen that surgery being done ever would know that answer. If you haven't, though, that's the answer. The answer is B. It's the Harm's trabeculotome, and that's what it is. So it's basically used for an ab externotrabeculotomy in childhood glaucoma, basically with hazy corneas. It has two arms, and you saw that in the video. The one which was inside the eye and which was towards the right it's actually used to open the Schlemm's canal, and the second arm is to basically guide the direction externally, because you can't always see it once it's kind of inside the Schlemm's canal, and unless you prior to turning it the other side. A trabectome is a mechanized handheld kind of device, but it's part of of the MIGS, which is now touted the world over. It is basically a handheld mechanized device, and it's basically used for ab interno-trabeculotomy. A Kelly's punch, all of us have seen that it basically is used traditionally for a trabeculectomy. And lectomy is one in which you actually make a kind of a opening, and it's used for removing the trabecular meshwork. Also removes a part of the sclera to kind of make the opening into the Schlemm's. And you can see those right there. With that, we come to the third question, or the MCQ 18. So a 4-year-old boy presented with left exotropia and had this fundus appearance. The right eye was unremarkable. What is the most likely diagnosis? Is it a retinoblastoma? B, is it an X-linked retinoschisis? C, is it a retinoma? And D, is it a subretinal cysticercus? And your time starts now. And that's a bit of a tough one, although, I mean, I'm sure a lot of you might have gotten the answer right. But the correct answer is C, it's a retinoma. What are retinomas? So retinomas or retinocytomas, it's kind of an interchangeable term. They're said to be benign precursors of retinoblastomas. They were initially said to be spontaneously regressed retinoblastomas, although that term is now kind of discouraged, because what that suggests to a lot of people is it was a retinoblastoma, it's regressed and requires no follow-up, although that is not the case, as will be seen subsequently. It's seen in about 1.8 to 3.2% of retinoblastoma cases clinically, and up to about 1 in 5 of retinoblastoma cases in enucleated eyes. It has the same genetic origin as a retinoblastoma, so basically entails a loss of both copies of the tumor suppressor gene. The histopathology is different. It has abundance of florets, eosinophilic cytoplasm, has foci of calcification, which is detected on histopath and also on ultrasound, but there is absence of Homer-right and Flexner-Wintersteiner rosettes, and there is no necrosis on histopathology. So it's said that every retinoblastoma was a retinoma when it was younger, but most go on to become a retinoblastoma, some remain at a retinoma stage and don't get that kind of malignant potential. The malignant potential is more and more in childhood. So the end of the first to second decade, there's about a 4% chance lifetime of a retinoma actually going on to malignant transformation. So once you see it, it's a difficult diagnosis to make. Lots of people would still want to treat a retinoma, but a clinical triad. So this patient had the typical clinical triad. It's a gray translucent retinal mass. It has typical cottage cheese-like calcification, which you can see clinically. You can also pick it up on the ultrasound. And it has surrounding RPE hyperplasia or chorioretinal atrophy, which is not seen in a retinoblastoma. The margins are well defined. It's kind of fairly well defined. And I'll just be showing you an example of a patient. So November 2013, top right, that's what he had. So we have about a 3.5, 4 year follow-up. Sorry for the bottom left photo, the March 2017, the montage kind of blurred out the temporal margin. But essentially what you can see is that it's not gone anywhere. It's a well-defined translucent structure, has those kind of cavities in, within it, has predominant RPE changes at the periphery or chororetinal kind of atrophic changes. And I haven't put the ultrasound, but you could see calcification in it also. Has remained the same. We continue to follow this patient up, and he has remained the same. So this is the kind of benign cousin, very rare, but a benign cousin of your dreaded retinoblastoma, the retinoma. With that, we come to the fourth question of this round, or MCQ 19 for the entire section. Again, a surgical clip. What procedure is shown in this video? I'm going to play the clip, and simultaneously, I'm going to be talking about the options. So, yeah, so which procedure is being shown? Is it A, vitreous-based dissection? Is it B, cortical matter removal? Is it C, anterior PVR removal? Or is it D, cyclitic membrane removal? And your time starts now. Yeah. So the correct answer to that question is D, that there was actually cyclitic membrane removal being seen. And in the first part of the video, you could actually see the ciliary processes. So cyclitic membranes typically occur due to secondary to chronic uveitis, JIA. We had a question on that in the earlier round. Secondary to chronic, long-standing, generally partially or untreated intermediate or pan-uveitis. It can also occur after multiple vitreoretinal surgeries, especially when retinectomies are made and anterior flaps aren't trimmed. After giant retinal tears, or in acute retinal necrosis patient. It can happen after fibrous downgrowth, after penetrating ocular trauma, when there is that sheet of kind of fibroblastic cells which grow on the ciliary body. Now, why the hullabaloo about cyclitic membranes? Well, they begin with causing a mechanical obstruction to aqueous production, because cyclitic comes from the ciliary body, so they're in the front of the ciliary body. Later on, they'll form kind of adhesions to the ciliary body. They'll call it tractional detachment, which so the aqueous production will go down further. And as that process keeps going on, and you must understand, generally these are inflamed eyes, that adds to the kind of insult. Because the ciliary body gets detached from its base, it tends to lose its blood supply, and chronically it'll go into atrophy. Then there'll be hypotony, and that hypotony eventually would lead to phthisis bulbi. The ultrasound biomicroscopy is the imaging modality of choice, since these will be in the retroiridal area, and your light-based imaging modalities like your ASOCT will not be able to pick them up. So we come to the last question of this section, which is as follows. So which of the following is false about this condition, which is shown? A, systemic propranolol may be tried. B, external beam radiotherapy is needed to treat the fundus lesion associated with this condition. C, it is associated with seizures. Or D, none of the above. And your time starts now. So, I mean, I'm sure a lot of you guessed that that was a Sturge-Weber syndrome. The correct answer is D, and we'll look at it in a moment as to why. This is, as I said, Sturge-Weber syndrome, or a tongue twister. It's an encephalotrigeminal angiomatosis. It's a sporadically occurring phacomatoses, not autosomal dominant like a lot of your neurophibromatosis tend to be. It's characterized by, sorry. It's actually characterized by a port wine stain of the forehead or the eyelid, seizures. There's developmental delay, and on neuroimaging there is ipsilateral tram tract calcification of the cerebral cortex. The ocular manifestations might be quite a few, but there are two major ones, with glaucoma being the most common, seen about 50%, multifactorial, generally secondary to raised episcleral venous pressure, and also an element of trabecular dysgenesis. but it's seen in about 1 or 2 patients. It's recalcitrant to most therapies. The other, which the lesion showed in this question, was is a diffuse choroidal hemangioma, in which is generally picked up in a stage when there is a big exudative RD. It might just be seen as an altered fundus appearance, as is commonly shown in textbooks. Systemic propranolol has now been established as a very good adjunct prior to any kind of surgery in these eyes, or just even prior to any kind of glaucoma surgery, to try and reduce the vascularity and reduce the choroidal and the ciliary body thickness, because that will prevent any of the complications secondary to filtering surgery. Well, the diffuse choroidal hemangioma, as was shown, requires external beam radiotherapy. If the facility is available, proton beam radiation, which is very, very expensive and difficult to kind of get together, or a PDT, which is something that is strongly recommended. So with that, we come to the end of this round. And while the the backend team do the tally and will tell us eventually who the winner is, I have the absolute honor of introducing someone who, quite frankly, I don't think requires any introduction. This is Professor Pradeep Sharma, sir. He is the biggest, we use the term doyen in ophthalmology, I think, to my mind, a bit too loosely, but I think with him, it just fits. He just fits the bill of that just so right. And I'm just going to start a little bit about where he's from, and then share a little bit what I have in common with sir a little bit. So this is, as I said, he is the professor and head of the section of pediatric ophthalmology, strabismus, and neuro-ophthalmology at the prestigious RP Center at AIIMS in New Delhi. And he's been a product of AIIMS all throughout, having done his MBBS, his post-graduation, and also his training there. And after that, he went on to get his specialty training in pediatric ophthalmology and strabismology in the US at the prestigious Jules-Stein Eye Institute in UCLA and the Wills Eye Hospital in Philadelphia. Has, if I start enumerating some of the awards, or in fact, even 1% of the awards or the orations bestowed upon him, I think we'd be here all day. I'd just like to mention one before I go on to one thing that I want to share about him personally, is that he is the first Asian, and I think that that's just a hugely proud moment for not just the ophthalmic fraternity, but I think all of Asia in general. He was the first Asian to deliver the NAP lecture, and was invited by the American Association of Pediatric Ophthalmologists and Strabismologists in Vancouver in 2016. And salute to you on that, sir. And squint, strabismus, growing up for a lot of ophthalmologists, training is not the easiest thing to try and look and kind of understand or conquer. But his book, and I'm sure most people on this, with us today would have either gone through his book or are still part of, the book that he kind of has made. It's a mandatory book for, I think, anybody who wants to do any kind of pediatric ophthalmology and strabismology, Strabismus Simplified. And it's an absolute honor, sir, to have you with us today. And you, sir, will be sharing the next pearl. And with your permission, sir, I would like to play the video of your pearl, sir.
Friends, today I am going to share a new surgical technique of reinforced plication as a strengthening procedure for strabismus. The advantages of plication over resection are several. It's the vessel sparing surgery, shorter operating time, less surgical trauma, less post-op inflammation and hemorrhage, reversible in the early post-op period, and there is no risk of lost muscle. Reinforced plication reduces the late undercorrection. This is a case of intermittent exotropia in which left lateral rectus recession and left medial rectus plication has been planned. I'll be showing here the technique of reinforced plication only, as we have described the muscle sclera muscle reinforced plication. A limbal anchoring suture is passed and a fornix incision is made in the conjunctiva at 8 mm from the limbus. The medial rectus is hooked with the Jamieson's hook first and then the Green's hook, and the muscle is exposed with the help of the lens hooks. The intramuscular septum and the check ligament is incised. The muscle is marked with GV paint at the desired measurements. 60 vital sutures are passed, imbricating the muscle with interlocking bites on either sides, ensuring that the muscle is well imbricated. Next, the bites are taken in front of the insertion and again into the muscle in a figure of 8. On either side, this is done. An iris repositor is placed and the muscle is folded over itself by pulling the sutures neatly. The muscle is tightened after the FDT has been done and the sutures are trimmed. The hook is removed. The conjunctiva is closed with 8 O-bifill sutures and the conjunctiva irrigated. Post-operatively, the 9 gazes show the desired alignment of the eyes. In the initial few days, a lump is visible, which disappears over a few weeks' time. And finally, the conjunctiva is much whiter and cleaner than even after what we see in post-op resection cases. If by chance there is an overcorrection, like in this example, the plication can be easily undone by snipping the sutures on the next day or even after a few days, making it an easily reversible procedure. This is a great advantage, and the other advantages over resection are all to be seen. We presented this technique of reinforced MSM plication at APOS, Washington DC 2018 and American Academy of Ophthalmology, Chicago 2018. Remember, the goal for ophthalmologists is 3D realignment to restore stereopsis. S4 stands for strabismus, sight, stereopsis and smiles, so that all can see 3D. This is to re-accomplish the mission of spreading sight and happiness for kids the world across, maintaining the stereopsis and restoring the loss. I hope this new technique will benefit all children, and thank you all for your love and affection. Thank you.
Thank you, sir, for that. I mean, as always, sir, very, very lucid, very succinct, and yet something which is, at least to my limited pediatric ophthalmology mind, I think something which is just path-breaking. And as I was just speaking prior to sir's video, having gotten my my niece operated from sir, I think little over a year ago, I know of all the things at the RP center names. I know that all the things about sir being an excellent surgeon and knowing his stuff. I'm not going to talk about that. I think that's common knowledge. I think just his humanity, his simplicity, his unending dedication to what he does. I have seen that firsthand. So it leaves me spellbound as to what question to ask. But I have two, sir, if I may ask just two very simple questions. One is that, sir, so now, sir, would you be using the plication in most of your cases in primary surgeries? Or is there a special subset of patients where you would prefer plication now that, the procedure works and you've shown that elegantly, sir?
First of all, thank you, Mohit. It's been a real splendid thing to be watching all of the presentations that have been there, and specifically yours. And I can tell you, you have inherited everything from your great dad. I think salute. So I think we really feel proud, and every parent would be happy to have a son carrying the legacy like you. So it's wonderful, wonderful. Yeah, to a question about plication, now more and more we are using plication instead of resection. There are very few instances when we still do resection, and in those also gradually we may shift to plication. The instances are when we have to disinsert a muscle and shift it vertically, or like doing a transposition procedure, then we usually resort to resection still, because then we have to disinsert the muscle and move it. But many people, and even sometimes we have done in plication also, the shifting can be done. So that is there, but although the resection would definitely have much free movement for So that would be one indication where resection is still being done. Otherwise, mostly we are doing plication for medial rectus, almost 99%. For lateral rectus also, we are shifting towards plication. There's a little hesitation that there may be a little lump which is more visible. But we have seen that even it works pretty well for lateral rectus also. And of course, other superior, inferior rectus, again, you can do plication.
Exactly. So that was actually going to be my next question. That would you recommend it for vertical recti as well? But you've answered that, sir. That
Well, inferior rectus plication is a good approach. Instead of even superior rectus recession, you may go in as a primary surgery whenever the inferior obliques are not overacting. You may do an inferior rectus plication. Otherwise, you must have read that inferior rectus resection was the third thing which we were doing for DVDs when other things had failed. But now IR plication may be the primary thing whenever we are not doing the inferior obliques.
Absolutely, sir.
Sir, I would like to ask Anurag. Anurag is a relatively junior pediatric ophthalmologist. Anurag, how do you feel about this technique and how easy it is for a commoner compared to a person like Dr. Pradeep Sharma? What do you think about the technique as a common man?
Yeah, I saw Pradeep sir's video when it was sent across and was inducted in the PPT. And the first question that I was having in my mind, was bearing in my mind, was the lump issue. That was definitely one thing that I was concerned. Sir had explained towards the last part of his video that the lump is there for some time, but gradually it flattens out. But there is a big but. What Pradeep sir is saying is what appears in Pradeep sir's hands. So I'll have to see whether it works out in my hands. I mean, I would be really worried. Sir himself has said that the lateral rectus could be plicated, but it produces a bigger lump because we have to resect more. We have to go up to 8 millimeters on the lateral rectus side. So whether or not the lump is visible, for how many days, and does it actually flatten out, not to cause anything, any cosmetic distortion later on, is what remains to be seen. But it's a technique definitely worth trying. I am an ocean junior to Pradeep sir, both in terms of skills and in terms of education. But still, sir has, as always, sir has given all of us a point to ponder. Thank you so much, sir, for that.
Anurag, I can tell you that we did last year a comparison of the plication being done by our senior residents and other colleagues. And it was interesting to see the learning curve is very little. And the results were almost as good comparatively. So that also we have sent for publication, and it is something which may come on. So I think anybody can take up. It's a relatively easy technique to learn, but very beneficial.
That's a huge impetus for somebody like me, sir. I'll certainly keep you posted the moment I started. Thank you so much.
Mohit, back to you.
Thank you, sir. Thank you, Dr. Anurag and Dr. Prashant, for that interjection. I needed it because, I think Dr. Anurag is the right person to pose a question, if I may use that phrase, to Dr. Pradeep Sharma, sir. And with those words, and after thanking sir profusely and requesting him to stay with us till the end of the quiz, we move to the declaration of the Section 4 winner. And again, a shout out to our back-end team who are very prompt with coming up with that. So and the winner is Dr. Jiz Mary Santosh from Chennai. So a huge round of applause and a thumbs up to you, ma'am. And as was said for the previous winners as well, please keep your phone on, and you should expect a Zoom link from our backend team, which will expedite the connection that you might have with us at the end of the quiz. Dr. Jiz Mary Santosh, congratulations to you. And with that, I hand the forum back to Anurag sir to bring with us to kind of round this off with the last section, and I'll stop sharing. Dr. Anurag sir, please.
Thank you so much, Mohit, for giving the cue again one more time. As I said, your punchy voice is perfect for the quizzes all across. Each one of us should take a bit out of your book. So welcome back, ladies and gentlemen, for the final section of the session before we go on to wrap this up with the announcement of the winner. I'm all excited to find out who it is. at the end of the day. Before I begin this round, a word of gratitude and acknowledgement to LV Prasad Eye Institute Bhubaneswar, who helped me out with the visuals for 2 questions. Their logo, of course, would come as the questions come on your screen, but I must call out to them. I must express my gratitude to Dr. Surya, Dr. Srikanth, and Dr. Amrita for providing the visual support for me to frame those questions that would feature in this particular round. Without any further ado, let's move on to the first question of Section 5, Season 2, Session 3 of Brain Teasers. Here it comes. Okay, there is a movie clip for all the movie buffs. Watch out, the movie clip. And the question will follow after that. All right, so that was our homemade, very Indian vigilante called Aparichit. His voluntary eye movements added flavor to his character. But what if you see the similar kind of eye movements that occur involuntarily in a patient? The condition, as all of you know, is called nystagmus, and that's on which our next question is framed. In the presence of which of the following morphological types of nystagmus, uniocular visual acuity estimation is ideally not done? Is it A, sensory nystagmus? Is it B, fixation nystagmus? Is the answer C, latent nystagmus? Or is it D, congenital nystagmus? Your time, ladies and gentlemen, starts now. Right, time's up. Answers in. The right answer, let's have a look at that, would be latent nystagmus. In the truest form, latent nystagmus is a rarity. It does not present with both eyes open, but when you close one of the eyes, it starts manifesting. It can coexist with strabismus, and the fixation switch is the trigger. And once nystagmus starts happening, the foveation time reduces, and so does the visual acuity. Now, this is about true latent nystagmus. Another morphological variant of this is a latent manifest nystagmus, where the nystagmus is manifest, but it increases in amplitude once you close one eye. In both of these forms of nystagmus, one eye should not be occluded to see the visual acuity of the other eye, because invariably uniocular visual acuity will show a reduced value. What you can do, though, is not occlude the eye completely. You can use a high plus lens or a Spielmann occluder, which will not cut off lights completely to the eye that is not going to be examined, the other eye. Congenital nystagmus presents early, and there is a null zone more often than not, and people adopt a strange head posture like a face turn or a head tilt to achieve that null zone and bring it to the primary gaze. And they're associated with relatively better vision because the foveation time is more. Sensory nystagmus, as we all know, is one of the worst to handle. It's due to a profound visual impairment and occurring early in one or both eyes. And if the onset is early, it's likely to be slow, pendular from a jerk morphology, which obviously indicates, contrary to what people around the patient, including the parents, believe, the pendular nystagmus, though slows down, it carries a bad prognosis, a worse prognosis than a horizontal jerk. So that concludes question number 1 in this section. Let's go to question number 2 in the section. A 7-year-old boy presents with a rapid onset of bilateral sulcus fullness for 7 days, followed by acute proptosis. A CT scan was done, which shows a homogeneous mass. An incisional biopsy followed, which revealed cut potato appearance. What would your diagnosis be in this patient? Is it A, granulocytic sarcoma, B, rhabdomyosarcoma? Is it C, periosteal hematoma occurring after a trauma? or is it D, orbital amyloidosis? Big Ben starts taking its stroll now. The catch points in this particular history are these. Is it the condition is bilateral, it presents with a sulcus fullness, and is a very, very acute history. The correct answer for this patient is granulocytic sarcoma, which is nothing but infiltration of leukemic cells into soft tissues. If you do a biopsy in these cases, you would see a lot of blast cells. If you do a peripheral blood picture, if you see a lot of blast cells, and they would present with in the peripheral blood smear, they would present with typical cytoplasmic granules called OR rods. Granulocytic sarcoma is more common in the acute leukemias, in acute myeloid leukemias to be specific, and AML, M3, and M4, which also carry better prognosis out of the spectrum of AML, are typically associated with the presence of OR rods. So OR rods always dignify or signify better prognosis. Rhabdomyosarcoma is also expected to present with an acute onset, but it is typically unilateral and not bilateral. Sulcus fullness also should be there, can be there. Amyloidosis is a lot slower in its progression and its onset. So that's about this question. Question number 2 in the round. Let's go on to question number 3 as we present to you with another audio clue this time around. Take a listen at this song from the era of the 80s. Okay, Lakshmikant Pyarelal, Nitin Mukesh, Lata Mangeshkar come together, and the innocent faces of Farooq Sheikh and Poonam Dhillon on the screen create this magic from Nuri. Some of you might have guessed the next question, which would be on Norrie's disease. So which of the following is not a feature of Norrie's disease? The choices are A, male to female ratio is 1:1. B, is it a potentially blinding condition? C, does it often present with early retinal detachment? Or is it D, phthisis bulbi can be a sequel? Which of these is not true about the condition? Your time starts now. It's a dreadful condition. Norrie's disease, not good for our patients to have it. The correct answer, however, in this particular, out of these 4 choices, is male to female ratio being 1:1. It's an X-linked recessive disorder. So females are usually carriers. They're not affected by the disease. They transmit vertically to their male prodigies. It causes a dysplastic retina, presents very, very early, causes a dysplastic retina, and very soon it leads to RD. In fact, within a few months. In the late stage of the disease, you can see hypotony and phthisis bulbi. There could be associated findings, a syndromal association with sensorineural deafness and mental retardation. The differential diagnosis does rest with ROP and APVR. However, with APVR, we hardly see RD this early. It's a chance finding more commonly. And with ROP, you would see the typical retinal changes in terms of its vasculature, which are not there in Norrie's disease. It just presents with dysplastic retina, ubiquitously or diffusely distributed all throughout. So that's it about question number 3. Let's go to the next question, which comes up on your screen now. Which of the following changes can we expect on ICG angiography in this 15 years old patient who is asymptomatic? A, non-specific mottling. B, choroidal window defects. C, narrowing of choroidal vessels into a confluence corresponding to the retinal vasculature. Is that something we see on ICG? Or is the answer D, none of the above? The clock starts ticking for all of you now. So this condition, no need to explain that, is FEVR. So in FEVR, if you do an ICG, you would find none of the above. There's no change because there's nothing that happens to the choroidal vasculature. The retinal vessels are the ones that are affected. They show a scalloped pattern. Choroidal vessels are normal, so there's no change. It is a familial condition which mandates the screening of siblings as a must. It's a red flag there. It remains silent for most, may be diagnosed accidentally. The commonest finding, if there is any change in the retina at all, apart from the vascular changes, the commonest finding would be an ectopic fovea, and there would be a strabismus or positive angle kappa as a result of the fovea shifting from its original location. So that's about FEVR, and that's about the question. Moving on to the next question, which would be the final for this round. These are the pictures of OB scan and anterior segment OCT of a 12 years old who has been diagnosed with Ehlers-Danlos syndrome type 6. What is your ocular diagnosis? Choice A, is it keratoconus? Choice B, is it keratoglobus? Choice C, is it a pellucid marginal degeneration? Or is the choice D, megalocornea? Your time of 20 seconds start here. Little tricky, you needed to look at the anterior segment OCT picture clearly to clinch the diagnosis for you. The correct answer for this entity would be keratoglobus. We'll just go back to show you the picture. You can see the shaded zones here. They still look symmetrical on the OB scan, but what's clinching is the anterior segment OCT, where you can see the central part of the cornea is actually relatively thicker than the mid-peripheral portions. That's what clinches the diagnosis of keratoglobus. And keratoconus, the opposite happens. The central part is the thinnest and the mid-periphery is thicker comparatively. So keratoglobus is associated with the limbus to limbus corneal thinning, but maximum thinning is in the mid-periphery. They can be associated with blue sclerae and hyperextensibility, particularly in this patient in question who had an EDS type 6. And the pellucid marginal degeneration presents most commonly in the inferior limbus, and the central part is quite regular if you do a topography. A reminder to all of you, as Dr. Prashant was mentioning in the initial part of the quiz, we are available on Facebook and YouTube as well. See that, if not for the questions, if not for the answers, but for the wonderful pearls given away by Dr. Kalpana and Pradeep sir in today's event. Please have a look at them, share this with your friends, the information, and they should go and watch. While that concludes the section, that also concludes this session of Brain Teasers, this particular edition. While the backend office is calculating the marks, they've got a bit of job to do. We switch on to a trivia question, which is obviously something that's only designed to bring in some fun element to the quiz. Take a look at another video clip taken from another movie. Look at it and have fun.
लेकिन उसे ऐसी चीजें हैंडल करने का तजुर्बा नहीं है। उसे कई 3-फेस सॉकेट में डलवा दिया, वो बेचारी तो जल जाएगी ना।
लेकिन वो ऐसा क्यों करेंगे?
4-5 बार पहले कर चुका है।
मैं अपनी बेटी की शादी कहीं और करूंगा।
बेटी की शादी?
हाँ।
ओह वेरी सॉरी, हमें लगा आप चाय की मशीन देने आए हैं। ओ ये पीजिए, चाय लीजिए ना।
रख दीजिए वहाँ।
राधा ट्वाइंग ट्वाइंग
ट्वाइंग ट्वाइंग हैं।
कितनी बड़ी गलतफहमी। दरअसल मैं अपनी बेटी का रिश्ता लेकर आया था, आपके बेटे गंगा के लिए। मैं नहीं दे रहा हूँ।
हाँ
अच्छा, अरे
देखो
कितनी खूबसूरत है। आप बैठिए ना।
ओह श्योर।
Well, this gentleman has come with a proposal for his daughter's wedding to somebody. Somebody comes with a proposal for his daughter's wedding like this, and has eyes like this. For my son, I would grab hold of him and immediately take him to the OT table. Right. So the question that follows this video clip is, this gentleman, which of the following cannot be the diagnosis for this gentleman in the picture who had heavily distorted eyes? Choice A, bilateral heavy eye syndrome. Choice B, bilateral cranial nerve 6 palsy. C, bilateral strabismus fixus. Or D, Chiantia syndrome. Your time starts now. Time's up. The right answer would be bilateral heavy eye syndrome. Heavy eye syndrome is another entity that presents with high myopic eyes. The first entity would be a strabismus fixus, of course, but bilateral heavy eye syndrome or a heavy eye syndrome is that condition wherein it happens in high myopia, of course, but the deviation is downwards. The eye is heavy because the globe is large, and the lateral rectus, which becomes progressively weaker and is unable to maintain its course on the lateral side of the globe, it slips under the globe and starts acting like the inferior rectus muscles. The lateral rectus and inferior rectus both combined pull the muscle down, producing hypertropia. Chiantia syndrome is an infantile esotropia syndrome, which is presented with a large angle esotropia and abduction deficit. And very commonly, since it's infantile, the patient adopts a head posture, a face turn, to preserve whatever limited amount of binocularity that he or she can. So Chiantia syndrome is associated with the heavy eye syndrome. With that, we come to the end of the section and end of Brain Teasers this edition. Let me announce the winner of section 5. Please hold it tight. The winner's name is Vijay Pai, Dr. Vijay Pai from Manipal. So claps to you, appreciation, gratitude for taking part. I'm sure you must have learned, like many others who have participated in the quiz actively here today. So that's the section 5 winner. Now we head back to the creator of this concept, Dr. Prashant K. Bawankule. There comes the middle name, Keshav Bawankule, sir, for announcing the session winner if we are ready with it. Sir, are we ready?
We have some more time. Can we have meanwhile one more trivia? We would need one
Certainly.
more.
Certainly,
we can
sir.
go back for a trivia. One more.
Yeah, certainly, sir. But for that, I have to stop sharing my screen for some time and unhide the hidden slides. I just hid the slides.
Sure,
Okay.
sure, please.
All right.
In the meanwhile, I would like to say about the last. Hello.
Yes, sir.
Yes, sir.
Please.
Yes, sir.
Please.
We can hear you, sir.
Interesting quiz. I mean, I'm really impressed by your interest in music and movies. It's really interesting because I find your Brain Teasers particularly is very engaging, entertaining, and educational. So all the 3 E's are there. So it's nice that you are trying to make education so interesting by using the other things. I'm also fond of music for the same reason. As I generally say, Strabis music. All my ICs have to have interesting thing. But the thing I would like to comment about the Chiantia syndrome in that person, of course, he was having a voluntary esotropia for the sake of the movie. But Chiantia would not present like this because they would have always fixing eye in adduction. So,
right, sir. Right, sir.
Chiantia syndrome would be maybe the correct answer.
Right. Okay,
That's a classic
so
teacher in him. That's a classic teacher in him. Anurag,
Yeah.
you still need to learn a lot.
I've,
You have a long way
I've
to
never
go.
denied that. Sir. I've never denied. I don't stand a chance before him. I mean,
This brain teasers is really teasing the gray matter to make the best use of it. So all of you, I think the entire team, I am really impressed.
Thank you.
Specifically so because when I returned from US in 2001, I was impressed by this quiz sort of thing. They were doing it in UCLA, a monthly quiz which was specialty based. So when I came back, we started doing in the RP Center a specialty quiz every week, and that was continuing for almost 15 years. That was a very good platform to teach.
Yeah.
I believe by quiz you can make the subject more interesting, and one topic which is being taught by quiz will never be forgotten. Whatever you may read 10 times, you'll forget, but something which you have got into the quiz. So really hats off to both of your presenters, Anurag and Mohit, and all the others also who have been doing for different sessions I have not seen. And the creator, of course, Prashant, the smile is there. So all, कहते हैं ताश के 52 पत्ते, all are really wonderful.
Thank you,
He
sir. Thank you
chooses
for your
his-
kind words. Anurag, meanwhile, we
Yeah.
have got the winners. So I think we will be directly going to declaring the session, today's winner. So the first runner-up today is Dr. Toshit Varshni from New Delhi. Congratulations, Toshit. You are requested to join. You are requested to join us on the Zoom platform for the felicitation ceremony. And the winner for the today's episode 3 is again Dr. Uday Tekchandani from Chandigarh. Definitely welcome, Dr. Uday Tekchandani. We request you to join us on the Zoom platform for the final concluding ceremony and the prize giving. So I hand it over back now to Dr. Shilpi for the concluding ceremony now.
Thank you, sir. Welcome back, participants. After a lot of adrenaline rush, learning, and fun. So, tired? Special welcome to today's winners who have joined us. Once again, congratulations and welcome. So, let me take a roll call for all the winners. Akansha Darda, Nagpur.
You have to wave your hand, Akansha. Are you there on the Zoom platform? Hello. Have they joined, Mr. Sai? Hello.
Hello. Yes, doctor.
Yeah, have the participant joined us?
Yeah, they are joining one by one, doctor.
Okay. So can we have a trivia meanwhile, or can we have some chat with Dr. Pradeep Sharma?
Yeah,
Anurag.
Yes,
Anurag,
sir.
I think you carry forward the chat with Kalpana madam. You need to learn a lot from them. Even now, I know that. So please engage her.
Of course, sir. So, do you want me to play the next trivia, or should it be just chit chat between?
It's good to get enlightened. I think this is a nice opportunity I have given you.
Okay, right. Yeah, thank you so much. So, Kalpana ma'am, I think we still have you. Can you please unmute yourself, ma'am?
Yes.
Ma'am, while we were discussing the plication technique with Dr. Pradeep Sharma, I just wanted to take your opinion at that stage, but since we were running a little late, so I just avoided that for a while. Do you adopt to this, or would you adopt to this? What do you think of this technique, ma'am? This
Actually,
novel technique.
after seeing Sir's video, we've started doing plications, more for medial rectus, small angle strabismus, and it has been really good. It is not very bumpy like Sir mentioned. And we've done, I think now almost most of our resections have become plication now. So when it's easy, reversible also. So it's a good technique to be adapted. And the learning curve is, like Sir mentioned, it is not really, very difficult. So just taking the suture, that is what is going to make the difference. But it's definitely a good technique. Sometimes the only thing is we had a lot of, queries whether the results will be as same as the regular or the conventional resection. But it's been good. So I think almost for the past
Pradeep,
1
sir.
year we've been doing.
Right. So you've been doing it for the last 1 year, and your
Yes.
results have been good. So very good to know that. Pradeep sir, you did mention, and we just heard Kalpana ma'am saying the same thing. It is reversible, and we all agree that it is reversible. But it is reversible till what time, sir? Till what time can you untie the sutures and reverse results? What's the cutoff?
We have done is 1 week. Usually you will be watching in the first post-op day, and then maybe 1 week. Sometimes if you missed it initially, or you think that, okay, little bit of overcorrection is acceptable. But when he comes after 1 week and we find, usually these are like in IDS cases when we have done and he's bothering you with more than 10 prisms of ESO, then you have to undo it. So in that case, it's possible even at 1 week.
When you undo it, do you titrate or do you just untie the sutures and do the whole procedure over once again?
And let the muscle fall back, so that because the adhesions have not formed very strong and the muscle has not resolved. Finally, what is going to happen is that these muscle spindles all will morph themselves, and finally the lump disappears for the same reason. The muscle spindles will remorph themselves, and so it will assume the final shape. But before, up to 1 week, you can usually do that. It will let the muscle go back, unfurl itself, and it will go back. Yeah, you don't have much of titration in this. This is, it's like a two-step adjustment that you can do. Either you have it or you don't. So if you have an overcorrection, you may undo it. And usually these are
redo the whole thing.
15 prisms, 20
Sir,
prisms.
I have a question.
Yes.
Can I ask you, Pradeep sir, that undoing of a overcorrection, undercorrection, does it ever happen at the hands of a gods like you, or you have made that proposition of undoing for people like less mortals like Anurag and me?
Yes. Before I volunteer, sir, before you mentioned my name.
Will understand that there is never like a perfect number. Undercorrections and overcorrections, we generally say that we only have two complications, undercorrection or overcorrection. So they can happen. And it's not that we will always have a perfect thing. Maybe 80-85% times we are having perfect ortho, but there may be 5 to 7% on both sides, under and over, which we have to.
Oh, I thought it is for less mortals like Anurag and me.
They're all the same.
And I think as trapeziologists, we all would agree that more than the under, we actually dislike to see the over. We really dislike to see a consecutive tropia. So it really serves us very well, these reversible or titrable procedures as we go on. I mean, the new technologies emerge. Prashant sir, are we ready?
Yeah, we are ready now. Back to Shilpi. Yep.
Good. Thank you so much, Pradeep sir.
I request all the participants to unmute, please. Welcome, Dr. Akansha, Dr. Uday, Dr. Ramana, Dr. Ziz. I think Dr. Vijaya is yet to join, and Dr. Toshit from New Delhi. So now we are all here. I request Dr. Anurag Mishra sir to felicitate and interact with the Section 1 winner, that is Dr. Akansha Darda from Nagpur.
Akansha,
Hi,
need to come on.
Yes, sir.
She is already there. You just need to orient your phone to a landscape mode, Akansha, so that we can have, good, brilliant. That's much better. Thank my sense and technology for this. Right. So hi, Akansha, how have you been? That's a very orangey smile coming from the city of oranges.
Thank you, sir.
Are you fond of them, oranges?
Yes, sir, of course.
What do they give you? They certainly do not, they might give you a bit of vitamin C, but they certainly do not give you endorphins, and you need a lot of endorphins to be able to answer those questions with such precision. Where do you get that from?
Sir, it's our old knowledge, and as Pradeep Sharma sir has said, that learning is best from the quiz, sir. What you have learned from the quiz, you never forget it. So that's true, sir. I have been following Dr. Bavankure sir's this brain teaser since long time, and I am truly grateful to him and for his team for initiating such a wonderful quiz for all of us who have lost their touch from academics, sir. Thank you so much.
What is your
But don't
specialty,
be,
Yes,
yeah,
sir?
I was about,
Your
tell us about
specialty.
yourself. Tell us about yourself a bit.
Yes, sir. So I'm Dr. Akansha Darda, done MS Ophthalmology from Government Medical College, Meerut, Maharashtra. And I have done comprehensive fellowship in cornea from Sadhguru Netra Chikitsalaya, Chitrakoot.
So we are lucky to have you in Nagpur now, Akansha. Thank you. Congratulations. Sai,
Welcome.
can you show us the gift voucher? Sai for Akanksha.
Just a moment, doctor.
Yeah. Now you share your screen. Please do share the gift voucher which is due for Dr. Akanksha.
Wow. Thank you, sir. Thank you so much.
Thank you. Congratulations once more, Akanksha. We are proud to have you in Nagpur. Now
Yes,
over
sir.
to Shilpi.
Now I request Dr. Mohit Dogra sir to felicitate and interact with the Section 2 winner, that is Dr. Uday Tekchandani from PGI Chandigarh. Before that, I would like to ask one thing. Basically, the nation wants to know whether Mohit sir shared the questions with you, because you are the runner-up also. And if this is match fixing, we have to look into the matter.
The cat is, we have been caught red-handed. The cat is out of the bag. He was supposed to, this was actually spot fixing. He was supposed to give me 50% of the earnings. But now that it's the cat is out of the bag, हम पकड़े गए. Because उदय ने आज तक कोई quiz नहीं जीती पहले. ये जिंदगी में पहली बार quiz जीता है. He has never won any quiz पहले. So yeah.
So Uday, what do you think? Was it a match fixing?
No, sir, not at all. I was not aware about these questions.
I think, sir, with Mohit's response, the opposition should rest.
So again, I think I know Uday personally. He's been with us at PGI for a very long time. He's one of our brightest, senior residents. Who's been with us, has won multiple quizzes, I must add, even prior to this at national fora. It was actually the winner of Erudio. Uday, please correct me if I'm wrong. A couple of years back, and was also one of the section winners at the inaugural, I think, season of the Brain Teasers in one of the sections. We keep holding quizzes in North Zones and Chandigarh Ophthalmic Society. So he has been a perpetual. I'm sick and tired of seeing his face winning prizes. So yeah. We should ban him, sir. We should ban him.
Yeah, he's a habitual offender, or what we should say. I think that
license cancel karo, sir.
Haan ji, sir.
No, but even if you do that, he will be able to reverse, because his name says that he's tech, so he would reverse the tech used against him pretty easily.
No, he's an avid quizzer, and he's otherwise also a sharp mind. I think both those things tend to help him be at this position time after time. So good on you. Good on you there. Good on you.
Congratulations, Uday. Now Shilpi.
I think Uday should say something.
नोट गिन रहा है मैम, वो सिंधी है, नोट गिन रहा है वो.
अच्छा सर, अभी नोट पहुंचने के हैं.
Thank you so much, Dr. Prashant and Dr. Mohit, for this opportunity. Thank you for Dr. Anurag as well.
I didn't give you the opportunity. No, ये सबके आगे नहीं बोलना.
It was an amazing quiz, sir. It was actually amongst the three brain tests, I felt this was the toughest, because a lot of pediatric ophthalmology, as Dr. Mohit rightly said, is something which is extremely niche and very difficult. I have really no idea how I have done this, but thank you so much to everyone, and thank you for the opportunity.
Uday, but we have the idea.
So are you trying to establish the fact that you are somebody who always swims against the tide, and you always come out as the victorious person when things do not run according to you?
No, sir, nothing of that, sir. I just think I just got lucky today.
Oh, that's humble. So Mohit, he still has his humility preserved.
Absolutely, sir. And half a paycheck to take home today, sir.
Yeah, I just wish it doesn't split it into half. Then nobody gets nothing.
I'm messaging Mr. Sai at the back end ki dekho ख्याल रखना. Jokes apart.
Let's move ahead.
Okay. Now after this, I request Dr. Anurag sir again to felicitate and interact with Dr. Ramana Fazal from Pondicherry.
Yeah, where is she? Hi, Ramana.
Hi, sir.
How have you been?
Very nice speaking to you. Yeah, I'm fine.
Okay. How is Puducherry? How are the sea breeze coming along?
Actually, now at present, I'm not in Pondicherry. I've come back home. I'm in Lucknow.
Okay.
But yeah, I came back from Pondicherry 3 months back. but I had registered in this brain teasers when I was there. So
you certainly look like a postgraduate, but are you?
no, I have completed my fellowship, sir.
Okay, you've completed your fellowship from where? Tell us about yourself, a few bits.
Yeah, so my name is Romana Patel. I did my MBBS from Calcutta National Medical College, my DNB from Arvind Eye Hospital, Pondicherry, and also my retina fellowship from the same place.
You are a retina fellow and you won section 3.
I have an interest in all. I believe it is necessary to have a working knowledge of all.
अनुराग सर, मेरे और आपके questions में ठीक नहीं थे. where
नहीं, actually, no sir.
कुछ हमारे गड़बड़ हो गया सर.
Yeah, Prashant sir, ask your subsequent quiz masters to be tougher because these guys are amazing. I think we were trying to stick to the bare basics, but they are far more than bare basics. So, yeah, coming to the looking like a postgraduate, even Mohit looks like a postgraduate, but he isn't. We all know that. So, Romana, what's your future interest going to be? Where are you going to be stationed, in Lucknow itself, or you want to go back to Puducherry?
No, I'll try to work in Lucknow only.
Good. You'll try to work in Lucknow in the company of Dr. Wahi and the likes, Dr. Sudhir. Plenty of good friends of mine stationed out there. Apart from excellent non-veg food, they're very hearty people. You love their company. Thank you so much for being with us, Romana, and winning this section. All congos to you. May you go a long way in achieving more in the quizzing industry. Thank you so much. And back to you, Shilpi.
Congratulations again.
Thank you, sir.
Welcome back, Dr. Ziz Mary. You have won the, I think, last section winner also in the last episode.
Yes, sir.
Yes.
So we have 2 habitual offenders, and unfortunately, I have the dubious distinction of having the questions on those rounds.
Interacting with
big cloud over my kind of morality now.
Yeah, but this particular offender, Mohit, has got another specificity. She has the habit of ending it with a bang. So she's winning the last rounds.
Yeah, absolutely. Ma'am, can you first of all, heartiest congratulations. I think very well done. And all of this is in absolutely a light vein. So I'd request everyone to take it in it's kind of tongue in cheek, but it's basically just to lighten the atmosphere after a little bit of tough quizzing. So ma'am, what do you do? Where you're based, and what are you trained in, ma'am?
Ma'am, sir, I'm basically from Kerala. I've been in Chennai for almost 18 years now. I did my MBBS from Ramchandra Medical College, Chennai. Then MS Ophthalmology from Regional Institute of Ophthalm, Chennai. And I finished my post-graduation 2 years back, and I've not been working since then. I have not done a fellowship yet. I'm going to do it soon. So
by the looks of it, you don't need to. I mean, maybe the practical part of it, but not the theory. I mean, it doesn't look like it.
I don't know, sir. I think I do.
Good on you. Good on you. I mean, I don't mean to undermine any fellowship anywhere. I think any education is good, but I think it's very creditable that if you have not had a formal fellowship training, and as you say that you haven't been maybe actively involved in seeing patients over the past few months, and yet you're keeping yourself abreast with knowledge. I think good on you. Super. Keep up that spirit.
Thank you, sir.
And this perhaps provides the perfect kind of fillip for you to go and attend the different entrance examinations or the entry exams for different fellowship programs running in different institutes. I think you're good on your knowledge background. Just build on it, and all the very best to you for your near future. Thank you so much.
Thank you.
Dr. Vijaya has joined. So I request Dr. Prashant Bhavanpure sir to please interact with her and hand over the gift voucher to her.
Dr. Vijaya, where are you? You can
I'm in Manipal.
Yes, ma'am. Good. Welcome, and congratulations once more.
Thank you.
Can you just tell us in short about yourself, what exactly you do, and what do you eat something specifically, carrots or something which makes your brain so faster and sharper? I always get a complex when it comes to concluding ceremony when I see people having so much of knowledge as well as being so fast. So is it the carrot or something like that? What makes you people click?
Possible. The carrot.
Might be the gold carrot that you dangle at the end of every at the end of every round, sir. I'm sorry.
No, seriously, if you look
I'm
at
getting
Mohit,
everything down to Nethi, I'm getting everything down to money, sir. Just lighter vein, sir.
No, I can
हम
understand,
सरकारी
but
लोग
look
हैं,
at-
हम कोई पैसे नहीं बनाते सर, तो मैं पैसे की बात ही करता हूँ.
Believe me,
इसका
Mohit,
मतलब बेसरकारी लोग पैसे बनाते हैं?
मैं ये कह नहीं रहा सर.
So coming back to it, Dr. Vijay, you can share us, what are you doing exactly, and how come you are so abreast in knowledge and so fast in it? What exactly is your qualifications and all? Please.
I think I'm the oldest one participant in this quiz. It's just that I like to take part in the quiz, as Dr. Pradeep Sharma said. These are the ones which make you pick up things very fast. I just wanted to know how quick or how good I am.
So what's your inference, ma'am? How good are you?
Not really that good.
No, but if
To
you
us, you
can
are
crack
very
into
good.
one section
Very
winner,
good, ma'am.
Dr. Vijay, it is a
Absolutely.
big thing. And you're
Absolutely.
in fact competing with the people who are just fresh outs. That speaks a lot about it. And in fact, if you say you are a senior amongst them, you definitely mean that people like us now need to go back and read and again come back. Because definitely if at your age you are doing it, it's a great credit to you. Congratulations once more, Dr. Vijay. Now,
Thank you.
Just to cap it, sir, I think, Dr. Vijaya, what I would like to say in the end, just before we conclude this, is that the last section was some sort of a mixed bag. So to win it, obviously requires knowledge across ophthalmology. So you did a great job, ma'am. Once again,
Thank you.
a bit of clap for you. Yeah, back to you, Prashant, sir.
I request Dr. Kalpana Narendran ma'am to interact with today's runner-up, Dr. Toshit Varshney from New Delhi.
Kalpana ma'am, you are handing over virtually the gift voucher to Dr. Toshit. What do you think about this guy, ma'am?
Congratulations,
Quiz him.
Toshit.
Quiz him. I really
Thank
don't
you.
know.
I can only
be
say by
super-
the looks, I do not know who he is, but with the glasses and he looks a little nerdy, so that's why he probably was the winner. So,
Thank you, ma'am.
yeah, Toshit, you want to say something about you?
I'm a final year resident in Dr. RP Center, AIMS. I've done my MBBS from Mananazar Medical College.
So you've been in Delhi and all the time, and to work under Professor Pradeep Sharma, it
Yes,
should be
ma'am.
really what is your field of interest?
I'm currently, actually, I am interested in pediatric ophthalmology. So
That's very
let's
nice.
see.
Good.
Currently finishing the residency and just studying whatever I can.
Good. Anyway, congratulations. Wishing you all the best
Thank you,
for
ma'am.
more orals to come. And
Pradeep sir, please unmute
ophthalmology is
yourself.
it's a good field. I think you should go for it, and it's got
Thank
a
you,
good
ma'am.
future as well. Thank you.
Thank you, ma'am.
Pradeep sir wanted to say something. Sir, yeah.
I was saying he's very good in music too. Toshit.
Oh.
Yeah. So I think that's another trait he has, which is wonderful.
Yeah, come and spend with me a couple of months after you're through with your residency, Toshit. And yeah, and tell us to win the couple of months time with me. You have to tell me the one incident, even if it's a singular incident, the one incident when you saw Dr. Pradeep Sharma angry with anything around him. Have you ever seen that?
No, sir. No, sir.
You've won your couple of months with me.
You have to ask my wife. She'll tell you how many times.
Right. Move on, Shilpi.
So here comes the most awaited prize for today's episodes. Again, Dr. Uday Tekchandani. And I request Dr. Pradeep Sharma sir now to please felicitate him.
I think it's really impressive, Uday. As your name sounds, you are the rising star. And with technology with you, I think you will definitely shine like the moon. So all your name is spreading all over. So it's wonderful. You have won the final prize. It's really congratulations to win this great prize. It's not the money, but actually the honor which comes along with it. It's wonderful.
Thank you. Thank you so much, sir. Thank you so much. It's an honor, sir.
So,
उदय सच्ची बताओ कौन से चक्की का आटा खाते हो, या वो ये मोहित के साथ सेटिंग है? वो हमारे ब्रेन टीजर गैंग का आदमी है, आप जानते हो उसे?
सिंधी 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 मैं ये
सर
सिंधी
पंजाब
बहुत
का आटा है सर, जो डॉक्टर मोहित खाते हैं सर, मैं वही आटा खाता हूँ।
सिंधी बहुत ब्राइट होते हैं सर।
अच्छा,
मैं तो
गोलगप्पे आटे में ही है।
So take the check is what we end with.
and then दान कर
Thank
दो
you.
मेरे को if we're doing brave, you know.
We'll keep the final one and keep the other one for you.
Chalo. So Uday, what is it that makes you come back to brain teasers on and off? Just one point. You don't need to pat us. Just a one point. Why?
Sir, it's a good, it's a good entertainment as well as refreshment on the first Sunday of every month. It's a good way to start your Sunday morning. So it's just enjoyable, sir. To just attend these quizzes.
पर उदय इस समय तो राउंड्स रहते होंगे आपके, इस समय तो राउंड्स रहना चाहिए आपके, आप राउंड्स छोड़ के कैसे क्या काम पे आ जाते, इधर क्विजिंग करने आते हो? मोहित ऐसे करता है
सर राउंड सर पेशेंट्स मॉर्निंग में देख लेते सर, और अभी वैसे भी
कोरोना
कोविड एरा में सर पेशेंट्स कम है।
सर कोरोना came to his rescue, तो कोरोना की वजह से आजकल राउंड नहीं, मतलब ग्रुप राउंड नहीं हो रहे सर।
पेशेंट्स कम है सर।
ओके।
अरे आपके चेक के तो बहुत सारे शेयर होल्डर्स हो गए उदय जी, अब तो कोरोना को ही देना पड़ेगा कुछ।
Chalo, once more congratulations everyone, all the winners. We hope to see you again on this brain teaser platform next year, next session. And our next session, as we have already announced, that it would be on 6th of September around 10 a.m. again. We would like to see you winning more prizes in the next episode as well. So now my last part of the duty is to thank all the people. Most importantly, I need to thank Dr. Pradeep Sharma sir and Dr. Kalpana Narendran madam, who in spite of being so tall, came down to our such a small program of brain teasers. I'm really indebted to both of you, ma'am, for sparing your valuable Sunday and accepting the invite to being a part of brain teasers. This is right from the bottom of heart, I mean it. Also to Anurag and Mohit, yes, they have wonderfully conducted today's quiz. You have both made it quite live, and I hope the participants really enjoyed it. My special thanks to Entod, who is making us see through this quiz session for this year and sponsoring us, our participants and our winners with such a big fat checks. And most importantly, I would like to thank my co-colleague, Dr. Shilpi, who is not only my right hand, who really takes all the stress out of me. She's working at the back office. Like Sai has his team, I have my own team who has Dr. Shilpi, Dr. Inkle, and Dr. Richa Gupta, who really work day in and day and night to refine this quiz to make it more palatable, more interesting, more informative. So really thankful to my whole team, and also to Numerotech and Sai for this wonderful back end work which they do. You might have seen the responses, the way we can predict the response or rather give the responses and all. So thank you one and all. Hope to see you again, and we would be meeting again on 6th September 10 a.m. again for next session, that is the fourth episode of our Brain Teaser session 2. Thank you. Thank you one and all.
Thank you so much.
Thank
everybody.
you. Thank you very much. Thank you. Bye-bye.
Thank you, ma'am, sir. Thank you, everyone, and congratulations to the winners. Thank you, Anurag, sir. Signing off.
Thank you, Anurag sir.
Thank you, Anurag. Thank you.
Thank you, sir.
Thank you. Bye-bye.
Thank you, ma'am.
And all the participants.